Okay, thank you. A very good afternoon, everyone. My name is Dr. Abhishek Thakur, and on behalf of MK Pharmaceuticals, I welcome all of you. I'm working as a marketing head for IVR division, and as you know, that MCure is a pioneer in field of gynecology and IVF. Programming 28 is a scientific theme for this year for our online webinars, and the concept of managing. In this concept, we are having a series of webinars on ovarian cycle with different gonadotropin, GnRH analogs, and hormones as per the different protocols. We will always be a preferred partner. I welcome for all the gynecologists and our KOL IVFs in terms of the academic which will provide support for all such initiatives. Today, we are very happy to be part of and to be partner for one such event. And I welcome Dr. Jyoti Malik to have a welcome speech and this session. Thank you, ma'am. Just to give a small introduction about Dr. Jyoti Malik.
I think Dr. Abhishek, the net is unstable. We'll just go straight. I'll invite the commentators. I think I'll invite the commentators. Can we have the CVs of commentators there? Can we have CV of...
from my side, but Nisha, is it visible?
No, your screen is not visible.
Your internet is weak. That is why it is not visible. Jyoti Malik, go ahead.
Okay, ma'am. Ma'am, I was just waiting for the CV to be displayed by them. But if it is not,
you can see
Mr. Abhishek.
Okay, ma'am. Just a minute. My colleague will share the screen. Give me 1 minute.
Okay. So thank you so much, I'm Cure, and on behalf of Fertility Forum India, I invite you all on advances in infertility treatment. And today it is my proud privilege to have 3 expert commentators here, none other than Dr. Shada Jain ma'am, Dr. Sonia Malik ma'am, and Dr. Asha Bakshi ma'am. So it is a proud privilege to have your comments on each of the talks that we have here. We would be having 6 talks here, and mainly on ovulation induction, how to monitor these cycles, what to do in hypo-responders, what to do in hyper-responders, how to monitor, to do ultrasound monitoring, where to use gonadotropin, the GnRH analogs, and how to tackle unexplained infertility. So that is the whole gist of today's webinar. And my proud privilege to introduce none other than Dr. Sonia Malik ma'am, the expert commentator for today. Ma'am would be joining us soon. She is past president of Indian Fertility Society. She is chair of Indian Infertility Committee of FOGSI in 2016. And she has been a past president of Indian Menopause in 2007-8. Ma'am is on an editorial board of the Journal of Fertility Science Research, a past editor of Journal of Midlife Health, and she is the director and HOD Nova South Infertilities and IVF. Has been awarded many awards and a thorough academician, I would say. Can we have the next CV, please? Next, we have a person who is, I don't know, I mean, words fall short when I look at ma'am's face. And the CV, though she has written just very few lines, it speaks volumes. Dr. Shada Jain ma'am is a teacher who just wants to just share her knowledge with everybody. She has been a faculty for the last for 2 decades at PGIM, Pijmer, Chandigarh, Lady Harding College, and she is the founder secretary general of the Delhi Gynae Forum, a body which started with very few people, but now this Gynae Forum has caught Delhi by fire, spreading academic fire everywhere. So thank you so much for joining us, Dr. Shada Jain ma'am. And I would just request you to speak a few words before we move on, because we have many talks. Just a few words, because that would be an honor to this platform.
At the outset, my sincere thanks making me a part of this prestigious webinar. And as you all know, that the ART has grown by leaps and bounds. And now the ART bill is right here. Till now, what has been unregulated, probably through this particular law will be great, will be disciplined quite a bit. And I feel, now the responsibility is there on the stalwarts who are sharing the platform here, to make a uniform kind of a thing, whether it's protocols, whether it's the drug use, the kind of things which are used. I think we need to streamline quite a bit. Till now, we find there had not been any much of transparency. People like to hide things, from each other. But I think the time has come, instead of quoting what is happening in America, what is happening in other places, we should have our own data and we should have our own guidelines. So we can definitely see there is a uniformity across the country, and we do not come into any conflict with the new law and what the ART people are practicing. The life should be very, very smooth for them. So I think with these kind of remarks, I think I'm going to get enriched today by the speakers who have done a hard work to speak on this particular forum. So thank you very much.
Thank you, ma'am. Thank you so much. And the third expert commenter, we have none other than Dr. Asha Bakshi, ma'am. Can you please change the CV? Next, please. Ma'am is a lead consultant at Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital, Indore. She is Vice President-elect 2022 from the West Zone of FOGC and has been the Joint Secretary of ISAR in 2021. And ma'am has been a founder, chairperson of many societies in Indore. The MP IAGE, MP ISAR, has been a chairperson of FOGC Infertility Committee, member of the ICOG Governing Council, and has organized wonderful conferences, a recipient of many awards. And ma'am is a person as beautiful as inside and out, and a person who is easily approachable and would be a wonderful guide and a thorough friend. Thank you so much, Asha ma'am, for joining. And I just would like a few words before we go on to the first talk.
Thank you, Jyoti, for such kind introduction. And indeed, it is an honor to be on the platform with Honorable Sharda Madam and Sonia Madam. I'm really privileged. And today the topics have been really selected very nicely. The topics which are of use to every gynecologist: unexplained infertility, ovulation induction protocols, hyper-responders. So I'm looking forward to listening to all these topics. And I think we should just go ahead rather than wasting time in these. Let's listen to the experts.
Thank you so much, ma'am. Thank you. And we would be taking your comments after every talk, whatever comment you would like to make, maybe your practical comments or anything.
That's okay, Jyoti ma'am. Just move forward, no problem.
Okay. So, Yukti, can you take over from here? Can we introduce our first speaker then?
Sure. I welcome you, Sonia ma'am. Ma'am has joined. Dr. Sonia Malik ma'am, can we have a few words from you before we start the first talk? Sonia ma'am, please unmute yourself. You're mute. Yes, ma'am.
Can you hear me?
Yes, ma'am. Welcome, ma'am.
Thank you very much for having me over for this as Dr. Sharda Jain and Asha have said, this is a really prestigious webinar with all the stalwarts here. Thank you very much for having me here with you. And before I say anything, I would like to salute to this dynamo, Jyoti Malik. From one webinar to another webinar. She's just jumping all along. and she's actually beaten COVID at it. So,
ma'am, please. Ma'am, we will take your comments later. Ma'am, thank you so much. Thank you.
This is the first comment. So to be able to spread so much of information and knowledge is not easy. But she's really done it with so many varied subjects, so many varied people. She's got together the best of the best. And I think that goes to her credit. Many, many congratulations to you, Jyoti. This is entirely your own single-handed effort. And I really say that you're great. Thank you very much for having me here. Thank you very much.
Thank you, ma'am.
Thank you so much, ma'am. I welcome all our expert commentators. And with all of your blessings, we'll begin the first session. Our first talk is on unexplained infertility. Can I have the slide, CV slide of Dr. Gautam Khastagir, please? Can somebody from the team help me out with the CV slide?
Yes, ma'am. Yes, ma'am. Give me a moment.
Go next, please. Yes, cool. Though Dr. Gautam Khastagir, sir, does not need any introduction. Yes, please, the next slide, please, Nakul. Yeah, cool. But sir is the founder, medical director, Birth, Gynoscopy and Wellbeing. He's the chairperson, Birth Inspire Foundation, and has been the organizing secretary, ISAR 2018 at Kolkata, chairperson, ISAR Bengal State Chapter 2020 to 2022, and so many accolades to his name. He's the recipient of Wellbeing Research Grant in UK, Reproductive Medicine Subspecialty Training at Royal College of Obstetricians and Gynecologists, RCOG accreditation in endoscopic surgery, and I can go on and on introducing sir. I welcome you, Dr. Gautam Khastagir. Over to you, sir.
Thank you very much. Thank you, Dr. Vadhavan, for that very sweet, kind introduction. And my immense thank and gratitude to the Fertility Forum of India for giving me this opportunity to see so many of our friends and sharing our experiences. Now, my regards to respected Sarda Jain Madam, respected Sonia Malik Madam, my very good friend, Narendra Malhotra, Dr. Asha Bakshi, and of course, without thanking Dr. Jyoti, I cannot start my talk. And as we have heard from Dr. Sonia, we know her enthusiasm for academics and organization. Now, if I may just share my screen. Now, the reason I chose to speak on unexplained infertility, because when I looked at the program, the academic plan, I saw that we are talking the most important thing, that is the ovulation induction, monitoring of it, different protocols. Then we are going to hypo-responders and hyper-responders, which is obviously we need to think about it, because we often feel the normo-responders will respond anyway. So what is so big thing about it? So I thought, let me speak about the normo-responders, and particularly those individuals in whom we really do not know what is the cause of infertility, let alone how we are going to treat them. And actually, we treat them by ovulation induction. So perhaps my talk will raise few aspects or issues which my subsequent learned speakers are going to cover and give the answer. Now, when we were medical student, we were told the 1/3 is male, 1/3 is female, and 1/3 is unexplained. But as time is progressing, we are finding unexplained infertility incidence is coming down. Now it is 25%, and in some papers it's saying 23%. This recent paper published in Human Reproduction showed that more you investigate the infertile couple, lower is the incidence of unexplained infertility. So in the bottom line, you will see it's only 23% if we investigate extensively. But if we do a sort of concise infertility workup, which is now the talk of the day because of the cost constraint, because of one-stop clinic, often we are only doing history taking, maybe a blood test, maybe definitely pelvic ultrasonography, and a semen analysis in one day, and that gives us maximum information. Gone are those days when you have to bring the patient in early follicular phase to check the FSH and LH. But by doing less investigation, actually the cumulative pregnancy rate is much lower. So on the top line, I have mentioned the live birth rate after 1 year of infertility workup is about 58% when we do extensive investigation. When we do less investigation, it is 46%. Now the question is, we have to find a cause. It is extremely frustrating for the patients because they think if there is no explanation, there is no definite treatment. And it is really frustrating for the doctors as well. But majority of the clinicians are now suggesting that we should change the name. We shouldn't call it unexplained. We should rather call it undiagnosed infertility. It is undiagnosed as yet because we couldn't find the specific cause. Why? There's lack of specific test and sometimes false negative test results or false positive test results. All of you know your patient has gone through hysterosalpingograph. There is bilateral cornual block. Maybe it's just because of tubal spasm, because it's painful. When you do a laparoscopy, you find the tubes are open. So you stamped her as a tubal factor, and now tubes are open. She become unexplained. There are many contributory factors of infertility which cannot be picked up by basic infertility evaluation, like if there is peritubal adhesion, if there is mild endometriosis, which makes the environment hostile to the egg and sperm. There may be tubal transport problem because of the damage to the cilia within the fallopian tube. It may be undiagnosed low ovarian reserve, sperm factor not picked up by routine semen analysis, and then problem with endometrial receptivity and implantation failure. Now the question we need to ask ourselves whether we should perform expensive and rare tests for all couples for diagnostic accuracy, or we should rather go ahead and treat these patients when the cause is not found with basic investigation. Now, what are the management we can offer? We often say the treatment is empirical. If someone is ovulating and then still we are giving superovulation, the sperm reports is normal, still we are doing IUI. Isn't it empirical? But not. Because what we find that many of these unexplained infertility patients may have early endometriosis, mild tubal factor, mild male factor, and immunological cause, which hasn't been picked up. So the treatment of these conditions are actually active management of infertility, and I'm going to talk about it just in a little while. So we do the same for unexplained infertility. What is our plan? Expectant therapy for 6 to 12 months. And what we mean by expectant therapy? We tell the patient about the ovulation time, fertile period, ask them to have regular relationship every 2 to 3 days interval, telling that the sperm survives for 48 to 72 hours and egg will only survive for 12 to 24 hours. But that can only be done if the woman is young, less than 35, and the duration of infertility is less. But if it is on the other way around, then we need to do aggressive therapy or active therapy immediately without wasting any time. Why do we do expectant treatment? Because we know spontaneous monthly fecundity rate, that's the background pregnancy rate, is about 2 to 4%. So if we wait for a year, 27% patients will actually get pregnant without any treatment whatsoever. That's not too bad. About a quarter of your patients, if they get pregnant, if they're happy to wait for that period, if they're young, then why not? But in our practice scenario, what happens is patients come to us as a tertiary center after going to many doctors. And if you tell them to wait, they will really get annoyed and they want to do something immediately. Because the most frustrating aspect of expectant treatment, it is not possible to predict. You cannot have any prognostic like high risk unexplained, low risk unexplained. So you do not know which couple is going to get pregnant and who is not. And also within what time frame. You cannot give any sort of guideline to the patient. But papers like this are suggesting that apparently we are over-treating 1/3 of all patients of unexplained infertility, and that is unnecessary. And it has been suggested that there should be some strategy to avoid over-treatment. So there should be some guideline by Fertility Forum of India that when we should start treating this patient and how. Now, what is active management? Active management is a term which is similar to active management of labor. So we don't sit around. We do whatever we want to do now within a time frame. NICE guideline from UK suggests that these couples should have 2 years of timed intercourse, that is expected management. And if it fails, go straight away for IVF. That's a little harsh, isn't it? So just straight away go for IVF. But truly, NICE guideline recommends that. Now, ASRM recommends that these couples should have 3 cycles of ovulation induction with IUI and controlled ovarian hyperstimulation with IUI. And if it doesn't work, go for IVF. But having said that, if women are young, if they have good ovarian reserve, there is a role of tubal flushing by hysterosalpingogram or saline infusion sonography, if not already done, because many a time we do not do tubal test. If there is no history of pelvic infection and previous surgery, we go ahead with ovulation induction with ovulogens like letrozole, clomiphene, and sometimes even with gonadotrophin. But before doing IUI or IVF, a tubal test is a must. Now, what is the aim of our treatment? We need to increase the background fertility rate. And from 5%, we need to increase to 10, 20, maybe 40, maybe 60%. And how do we do that? By improving the gamete quality, the gamete number, and we need to facilitate the gamete interaction. So what do? We offer them active management with controlled ovarian hyperstimulation or superovulation with IUI. Superovulation will correct the subtle ovulatory disorder, increase the number of egg released. It will bring the ovary close to the fallopian tube and thereby help in ovum pickup, increases tubal vascularity to enhance the ovum pickup mechanism. And by semen preparation, we enhance the fertilizing capacity of the sperm. And of course, by IUI, we bring more effective sperms close to more than 1 egg, which are being released by ovulation induction. But the question is, when do we do it? It depends upon patient's age, duration of infertility, and previous pregnancy history. And this algorithm will tell us how to go ahead. Less than 35, duration of infertility, less than 3 years. You can definitely give expectant management for 2 years as long as your patients are happy to accept it. You cannot force it in India. It's a democratic country. You give them different options, and it is up to them what they're going to choose. When you do ovulation induction with HMG, maybe 6 cycles of IUI can be offered, followed by IVF. But if the duration is more than 3 years, again, straight away go for ovulation induction, IUI, followed by IVF. If they are more than 35, duration is just over 1 year, you straight away go for ovulation induction with gonadotrophin, with IUI, only 3 cycles, and go for IVF. If it is more than 40, all of us know it's no point wasting time. Let's go ahead with IVF. Now, let's look at all the agents with unexplained infertility. I'm not talking about clomiphene in PCO. I'm talking about clomiphene in a normoresponder who doesn't have any ovulation problem. So surprisingly, the pregnancy rate per cycle is more or less same as what would have happened if they would have not taken. Now, our good friend Shiladitya Bhattacharya, who is a professor in Aberdeen and editor of Human Reproduction Online, said that live birth rate is same whether you give clomiphene or whether you give nothing, sugar tablet. So what ASRM has also shown that you need to treat 40 patients with clomiphene, 40 patients of unexplained infertility to get just 1 pregnancy. So think about it. Should we do it? In my opinion, if the patients are not happy with the expected management, perhaps you are showing them that you are giving something, but expecting the results of expected management. So when you are giving expected management for maybe 1 year, 2 years, give some ovulogen like clomiphene or letrozole. Again, letrozole in unexplained infertility is as good as clomiphene. But if you are thinking of giving gonadotrophin for IUI or IVF, letrozole will reduce the amount of gonadotrophin and thereby reduce the cost of the treatment. Coming to gonadotrophin in unexplained infertility, pregnancy rate is still pretty low, only about 7 to 8%. And it has been shown that with oral, it is better than the oral medication. But the same author, in a Cochrane review published within a period of 7 years, so 2002 and 2009, they're saying the pregnancy rate may be slightly higher, but live birth rate is same. So maybe the pregnancy with clomiphene citrate have a higher risk of miscarriage in comparison to those with nothing like expected management or natural cycle. And there is no significant difference of live birth rate between clomiphene and HMG. Let's look at IUI, simple IUI without any ovulation induction. Monthly fecundity rate has been reported between 4 to 7%. So it is said that IUI in an unstimulated cycle is as good as timed intercourse. Why bother? Why increase the expenses? And the success rate of simple IUI is as good as with clomiphene or without clomiphene. However, when we give gonadotrophin, our success rate improves from 8% to 18%. But we all know the success comes in the first 3 cycles. And on the 4th, 5th, and 6th cycle, the success rate will plateau. So many of us will only offer IUI with gonadotropin for only 3 cycles. And this was confirmed in a Lancet paper in the year 2017, where they said that IUI with ovarian stimulation is a safe and effective treatment in women with unexplained infertility, particularly should be done where the expectant management didn't work. So this should be the first line of treatment of unexplained infertility, according to this paper in Lancet. Now, in the same volume, there was another paper published by another group of people on the same topic, and they also agreed, but they said if the patient is older, we shouldn't do IUI, we should go straight away for IVF. But they also commented if the patient is very young, say only 25 or 30, then really we should think about what we should do, maybe expected management, maybe just oral Ovulation, rather than going straight away for IUI. Now, let's look at the Cochrane database evidence. Now, this is a very interesting publication which came in 2019, and it said the live birth rate between the 5 treatments we can offer, that is expectant management, ovarian stimulation on its own, IUI on its own, they together, or IVF, apparently the live birth rate is same. Interesting, isn't it? But when you think about the risks of ovulation induction, there are 2. One is multiple pregnancy and one is ovarian hyperstimulation. So when you're doing ovulation induction just on its own or for IUI, you cannot control multiple pregnancy, which you can with IVF. Because with IVF, although there are many eggs, you actually transfer only one blastocyst. That's what we do in majority of the cases. But when it comes ovarian hyperstimulation, that can happen both with IUI and IVF. Now, another Cochrane Library publication just 1.5 years back, coming up to 2 years, showed that for unexplained infertility, intrauterine insemination is very good, and it is better than expected management. I've already mentioned that IUI in the natural cycle is actually slightly better compared to ovulation induction and timed intercourse. However, IUI in a stimulated cycle will result in much higher success rate than IUI in a natural cycle. So the bottom line is, if we want to stimulate, then let's do IUI together. If you do not want to stimulate, perhaps timed intercourse is good enough, or you can give oral Ovulation and timed intercourse. Now, if we compare between IUI and IVF, it has been reported there is no difference in live birth rate between IVF and IUI with or without ovarian stimulation. But this is rather an old publication published nearly 20 years back. And they were saying that higher efficacy of IVF remains unproven. But that is not actually true. And many people like Roy Homburg said, initial treatment of should be IUI rather than IVF, which I will agree, which I will definitely agree. So in an untreated patient, just after expected management, is no point jumping to IVF. We can give few cycles of IUI and then to IVF, particularly in a country like India, where the cost constraint is there. And it is also said that both IUI and IVF is better than the expected management. Now, this debate whether to do IUI or IVF happens throughout the world. If you look at American Fertility Society debate, the jury is still out. Out of 4, 2 are saying IUI first, and others are saying no, straight away go for IVF. And the same thing was studied by Cynthia Furker's group in New Zealand. Now, New Zealand is a small country. They have fewer patients. So I jokingly said there are more ships than human beings in New Zealand. So doctors have ample time to do research, which in India, we find it very difficult. But I sincerely support respected Sarda Jain's madam. Gone are those days reporting just foreigners. Let's have our own data. And that's what we all are trying to do now. So they said ovarian stimulation and IUI is a low-cost, less invasive therapy to IVF. And these patients should have at least 4 cycles of ovarian stimulation with IUI. So either 3 or 4 cycles before going to 1 or 2 cycles of IVF, rather than going to IVF straight away, because it will bring apparently higher cumulative birth rate. So you are having 6 attempts, 4 IUI, 2 IVF. So more chance of higher cumulative birth rate and lower cost per live birth. So total cost may be higher, because IUI followed by IVF in comparison to straightaway IVF, but cost per live birth will actually be lower. Now, if we just focus on IVF and unexplained infertility, Cochrane database publication by my good friend Shiladitya says, although it's about 6-7 years old now, IVF is associated with higher live birth rate than expected management and also unstimulated IUI. And Shiladitya, being an academician, what I hear, the whole of UK and Europe are not really in favor of IUI. And what they're saying, if you have patients who have been treated with clomiphene and IUI, IVF appears to work much better than gonadotropin and IUI. So that is exactly what I have been telling. Gonadotropin and IUI is very similar to IVF. So if you have patients who had clomiphene and IUI, for them IVF will give a better result. But in those patients who never had any treatment, there is no difference in live birth rate between IUI, gonadotropin, and IVF. So although they are saying we don't do that much of IUI, we straight away from expected management, we go to IVF. In Cochrane data, they are analyzing the papers from throughout the world, and they themselves are saying, although they don't do IUI in UK so much, they are saying you can do IUI rather than IVF. Canadian Society are suggesting better to go for IVF early because it gives improved live birth rate and reduced incidence of multiple pregnancy. So time to pregnancy is much quicker, and you will have all singleton and rather than higher order multiple pregnancy. And finally, you have a group of patients whom you plan to do IUI and you had to convert it to IVF because they hyper-responded. Now, these patients, if you compare with the standard IVF, what we find, the pregnancy rates are very similar, slightly lower, very similar. But the miscarriage rate is significantly lower. Why? Because the quality of the eggs are better. Synchronization between embryo and endometrium is better because there is no hyperestrogenic state. And therefore, take-home baby rate is very good and similar. And most importantly, they are less costly and more patient-friendly. So time has come for us. I know it's not widely practiced in India, the mild stimulation. Often people say, okay, if we are serving a meal, we will serve 5-course meal. But think about our economy. Maybe only 1-course meal is good enough to be happy and to fill our stomach and our soul. Now, finally, earlier it was said the patients with unexplained infertility, when they are having ART, they should always have ICSI because the failed fertilization rate of IVF is 30%, whereas ICSI is only 10%. We know there may be subtle problem in the sperm, so we better inject them into the egg and make sure the fertilization. And it was quoted that it should be the first option and first line of therapy by my very good friend Adam Ballin, with whom I trained in United Kingdom. But currently, the trend is with the advances in the lab facility, failed fertilization rates are much, much lower. So no one is saying that we should go for ICSI straight away. We will do it in the second attempt if there is failed fertilization in these patients. So at the end, I will bring 2 interesting papers, one from the each side of Atlantic, one from America. What they are saying is the evidence-based treatment for unexplained infertility, the guideline is most couple with unexplained infertility. The initial therapy is 3 or 4 cycles of ovarian stimulation and IUI. They are saying either by CC or letrozole. They are not saying gonadotropin, but we know gonadotropin has a higher result than CC and letrozole when we are doing with IUI, followed by IVF, who were not successful with IUI. But what they're suggesting that we should have something in between as a bridge between IUI and standard IVF. And that bridge, I personally feel, is the mild IVF or low stimulation IVF. And that is much more acceptable to the patient economically. And they accept, even if the success rate is slightly lower, instead of jumping straight away to the standard IVF, where you couldn't find any cause, you couldn't give any explanation, IUI didn't work. Maybe in my approach, first IUI, then mild IVF, and then finally standard IVF. Now, this paper was published in Human Reproduction, and they guided us the top 10 priorities for future infertility research. And this is an international consensus development study. And I've highlighted many of the thing. Out of the 10, the 6 is on unexplained infertility. They are trying to develop a predictive model to compare the outcome of treatment of unexplained infertility. They are asking what is the optimum ART, how we should approach ART for them. And I would love to listen from my subsequent speakers their opinion on that. We do not know what causes unexplained infertility. That is the main dilemma. We need to investigate further. Does hysteroscopic removal of endometrial polyp increases live birth in unexplained infertility? Do we need to remove intrauterine adhesion? I'm sure Narendra Malhotra sir will comment on this because he's doing a fantastic work both with ultrasonography as well as hysteroscopy. And finally, if a woman has uterine septum with otherwise unexplained infertility, do we need to remove it? So take-home messages, diagnostic modality, ovarian reserve, sperm parameter, and tubal assessment. And tubal assessment, not just patency, but we need to identify if there is peritubal adhesion, if we need to find out any investigation which can assess ciliary damage. So it's not just tubal patency, it's tubal motility and function which are most important. And as regards the treatment, expected management can be offered in a young couple with short duration where the prognosis is good and where there is fund shortage, limited resource scenario, but we need to explain the success rate is not very high. Before switching to IVF, one should advise 3 to 6 cycles of ovulation induction, be it with gonadotrophin, be it with oral ovulation. In my opinion, gonadotrophin, because you do not get that many times. You only have 3 cycles of IVF, 3 cycles of IUI. So better give injection and have better success rate. And then go for IVF. But where the ovarian reserve is low, duration of infertility is long, and the cost is not an issue, perhaps IVF is the answer. So I thank sincerely, thanks from me and my team for a patient hearing. Thank you. Thank you.
Thank you so much, Dr. Gautam Kastagir. May I please request Dr. Sharda Jain ma'am for her expert comments?
I think, at the outset, I must congratulate Dr. Gautam to review everything detailed about the unexplained infertility. This subject has also fascinated me. When the NICE guidelines came in 2013, all Indian doctors said, "Nahi, ye to 2 saal mein to aise hoega hi nahi. We must be more practical. Our people are poor and things like that." But I think each one of you who will share experience, I said, okay, they say 2 years. They have a very sound background when they say make a guidelines. All experts sit down with a thick data with them. So if they say 2 years, at least Indian gynecologists ko 5 saal bana le. But I think very rightly you have said that these people should be investigated. I'm always for one. If you're taking your patient for IUI, her semen examination must be done, which we find that nearly 25% will do semen examination on the day of IUI for the first time. Tube testing must be done. And I feel, that the conservative treatment should be kept to very minimum. If the patient is less than 25, okay, conservative treatment. If patient is less than 30 years, and we know we have a premature aging as far as ovarian functions are concerned, we should be definitely doing an IUI, less than 30 years. But that should be restricted to ovulation, but I prefer gonadotropin because I think that gives a success rate definitely mounts out. And I think all of us are very good in monitoring ourselves. We exactly know where the things are going wrong. Indian patients do not mind in case if there's a multiple pregnancy. So I feel, 3 IUI as you had already suggested, but any time when they pass 35 years, no IUI, nothing, she should go for IVF. So this is what I feel about it, that we must, there has to be a cause. Whether it is a mild endometriosis, whether it's an unknown tubal pathology, whether the sperm functions like DNA and all, DFI is all not done in such patients. So we do not know what the things are. But I feel, that we should respect NICE guidelines. For them, it is for 2 years. And for us, it will be probably 5 years. You take it from your data has suggested that IUI left and right does not help them. You need to make a guidelines for ourselves and not bank upon again what UK people say and what American people say. I think all of us have enough thing. Dr. Bakshi and Dr. Sonia Malik should be able to also express their own experience as far as unexplained infertility is concerned.
Thank you, madam. I felt so reassured that I'm in the right track, doing right thing. Thank you for your comments, madam.
Thank you, Sharda Jain, ma'am. May I please request Dr. Sonia Malik, ma'am? Ma'am, for your words of wisdom.
Please, I wasn't here in the lecture. I've just joined back. Let me not comment on this. Let Asha do.
Okay, yes. May I request Dr. Asha Bakshi, ma'am, for her expert comments?
First of all, congratulations, Gautam, for such an excellent talk with lot of evidence. And you are an expert in evidence, providing evidence. I know it right from Northampton days when you were favorite of all our consultants and you were the gold medal candidate. So I know you very well and thanks. But one thing I would differ here, Gautam, is about you think that first IUI should be done, then mild IVF, and then normal IVF. I think either it should be IUI or IVF, and we all should be doing modest stimulation in IVF. So we can't keep on wasting time. And another thing in our scenario means I am doing that, and I would like your opinion also, that if you give something like letrozole and you give few doses of gonadotropin, say around 7, 8, 9 day or something, and then do IUI, that protocol also works well. And with letrozole, you don't get that many multiple pregnancies. So maybe that is something for our Indian scenario. I think that is something worth investigating.
Yeah, Asha, thank you. Thank you for your kind words. Yeah, it is true. I fondly remember those Northampton days with Professor Shackstead, Mr. Bibi, and Roy Davis, and Mr. Elliott. But coming to the topic, okay, I agree with you that the patient's IVF, standard IVF gives much better success rate. In my experience, what I see, particularly in Eastern India, where the socioeconomic condition is much lower than the other part, patients will say we can only have IUI, we cannot afford to have IVF when we offer them IVF and tell them the cost. So I've been practicing in Kolkata for 20 years. So in the first 10 years, what happened was I lost many patients. So I'm not saying it's scientifically best, but in our scenario, in my experience, it is like if you offer a 3-course meal, it is very good. But if you offer just 1-course meal or nothing, then so we are taking it just as a compromise because they cannot pay. And even if the success rate is lower than the standard IVF, it is higher than IUI. It is higher than IUI. So most of the papers are not saying, I haven't shown even a single evidence that mild IVF, but they have made a comment that we need to have some treatment between IVF and IUI. Why do they say that? That is what we need to investigate and find out for our poor patients. And I totally agree with you that letrozole is a very good drug. It can avoid multiple pregnancy. So in my practical experience, what I do is I do not give expectant management. I usually put them on some form of Ovulation and ask them to try on their own, maybe for 6 months. And if it doesn't work, then I offer them IUI with gonadotropin. And if they cannot afford gonadotropin, then I deal with letrozole and gonadotropin. And then I offer them IVF. Now, as I have said, many of them cannot take it. And I'm presently sitting in my rural clinic where I come once a week, and we could only offer IVF in a rural clinic by doing mild IVF. So this is a compromise. Maybe I'm not addressing the science perfectly, but sometime as a clinician, as a human being, we have to think about the patient's choice. Thank you, Asha. Thank you.
Thank you so much. Thank you, Dr. Gautam, and all the very best. You are contesting for honorary librarian ESAR, and I'm sure we all, if you join, I mean, you all the very best to you from all of us. Thank you so much for such a lucid talk. So now, Yukti, I think straight away, without introduction and things like that, I'll go to my talk as to save time. And we would be talking on very basic, and I'll just take everybody, some things Dr. Gautam has spoken, some things my senior mentors will be speaking, but maybe just brushing your knowledge basically again on the ovulation induction protocols. I'll take you through this. And since 1/4 of our couples with infertility suffer from ovulation disorders, and therefore we thought of taking up this topic today on this platform. And the clinical approach to this ovulation induction depends on the cause And it could be hypogonadotrophic hypogonadism, it could be premature insufficiency, or it could be hyperprolactinemia. And all these three contribute 5 to 10% each. So the major chunk is the WHO type 2, which is PCOS, which contributes 70 to 85% of these cases. Now, where do we do ovulation induction? Where there is no ovulation, that means the women are anovulatory. In those cases, we cause ovulation induction. That means it is either hypogonadotrophic hypogonadism women, or it could be the PCOS who are normogonadotrophic, normoestrogenic. And the women who are ovulatory, though there who are undergoing IUI or IVF, there we do a controlled hyperstimulation. That means though they are ovulating, but still we are controlling their stimulation and we are getting a little more than what they are producing. So in anovulatory, our goal is to have single follicle. It should be least invasive and simple and cheap. Whereas in controlled hyperstimulation, we want multifollicular development. And when we develop many follicles, there is a premature LH surge. We need to prevent that. And every time we have to focus that we have to have a minimum high order pregnancies. That means we have to rule out multiple pregnancies. I mean, we should make it a point that we maximize the rate of singleton pregnancies and we minimize the risks of OHS. So whenever we are doing hyperstimulation, these two basic things have to be taken in mind, kept in mind all the time. So why are we needing ovulation induction? As Dr. Gautam's slide suggested, when only IUI is done, only 4% will conceive. When we add CC to IUI, it becomes twice. That means 8% pregnancy rate is there. With the gonadotrophins, again, there is 8% pregnancy rate. And when we add IUI to gonadotrophins, again, it doubles. It becomes nearly 17-18%. So that is why just to improve our pregnancy rates, we are doing this induction. And what all are the things, what all are the drugs that we use? We can use clomiphene citrate. We can use aromatase inhibitors, letrozole being the favorite, gonadotrophins, and we can add these oral ovulogens with gonadotrophins, and sometimes with gonadotrophins we use GnRH analogs. So rushing through this, how clomiphene acts. Clomiphene is a selective estrogen receptor modulator, and it binds, by its structure, it binds to the hypothalamic estrogen receptors and thereby increasing the release of FSH from the pituitary. So baseline, how we do it, we do a baseline scan. On the day 2, we rule out ovarian cysts and we start the clomiphene citrate from day 2 to day 5. So it can be started from day 2, it can be day 3, day 4, day 5. The results do not change depending on the day we start the clomiphene. So more probability is most of the people start 50 mg, but with 50 mg, the problem is that only half of the patients respond. Half of the patients may not respond. So with the dose of 50 mg, we have ovulation of 50%. And when we increase it to 100 mg, our ovulation increases. So nowadays, it has become a common practice to start with 100 mg and then reduce it to 50 mg if needed. And there is no advantage at all by increasing it above 150 because, see, the results are the ovulation rate is decreasing as we are increasing the dose. The conception rate is decreasing. And why is it happening is because beyond 150, the anti-estrogenic effect of the clomiphene starts acting and the cervical mucus becomes poor, the endometrial development, the endometrium becomes poor. And therefore, what we can do is that we start the clomiphene early so as to prevent the anti-estrogenic effect. So even one can start even on cycle day 1 or at the most on cycle day 2 to give a longer CC-free period before IUI, and or maybe one can add gonadotrophins to overcome this anti-estrogenic effect. But even if there is no improvement, then one can go onto the gonadotrophin cycles. So with this algorithm, once we have given 50 mg for 5 days, if our patient is ovulating, we understand we see the endometrium. If the endometrium is good, more than 7, we continue for 6 months. But if for 6 months also, if till then the patient has not conceived, we call it a CC failure. And thereby we start again diagnosing where we went wrong. We start seeing the tubes again, we do a diagnostic laparoscopy, we reevaluate the hormonal profile. Now, if with the 50 mg, if after we have increased to 100 mg and still the patient is anovulatory, we can increase to 150, and still if it is not, there is no ovulation, we either rule out a persistent luteinized unruptured follicle, or we label her as CC resistance, and again reevaluate the hormonal profile, the LH, FSH, TSH, testosterone, etc. And in some cases, even 50 mg may cause hyperstimulation if the patient is very thin. So we reduce the dose to 25. But we should be careful of the side effects, because many patients will complain of hot flushes, nausea, vomiting, breast discomfort, headaches, and visual disturbances, blurred vision. So we have to stop if there is any such, if she has such serious side effects. Multiple pregnancies can occur, and in as many as 5 to 10%. So what about aromatase inhibitors? How are they different from clomiphene citrate, and how do they work? Now they limit the enzyme on the where androstenedione is getting converted to estrogen. So this is somewhere how it is. This is the place where letrozole or the aromatase inhibitors act. So they cause aromatase inhibition here and prevent the conversion of androstenedione to estrogen. When the estrogen is less, the negative feedback gets stimulated. The hypothalamus pituitary axis starts giving out follicles for FSH, which starts preparing acts on the ovaries and makes the follicles. But what happens here is that once the follicle is developing, we get the estrogen. Once the estrogen level again increases, further FSH stimulation doesn't occur. The FSH levels start falling, and thereby the other follicles undergo atresia. So this is the difference between the two. Here, since these receptors are blocked, as the estrogen levels are being perceived low, even though FSH is produced, the E2 is produced, but still it is perceived that it is not there. And thereby more and more FSH is being produced, and thereby there is multifollicular development. Whereas in cases of letrozole, these receptors are not blocked, and thereby once a follicle grows, the estrogen rises, and that estrogen restores the negative feedback, estrogen negative feedback on the gonadotrophins, and thereby only a single dominant follicle develops, or there is a monofollicular development. So this is the basic difference in letrozole and clomiphene. They block the receptors, whereas these act on the enzyme, on the aromatase. Now the Cochrane also says that the letrozole, now has letrozole taken over clomiphene in our practice? What the Cochrane says is that it appears to improve the live birth and the pregnancy rates in anovulatory PCOS compared to clomiphene, though the evidence is still low, and we need to take it with caution. Now, this was a very recent review of the Cochrane review of 2018, where they compared letrozole with clomiphene in PCOS, and they saw that the live birth rate and the pregnancy rate was increased with letrozole, but there was no difference between the OHS rate, the miscarriage rate, and the multiple pregnancy rate. Now, also they're comparing letrozole to the laparoscopic ovarian drilling. The letrozole the live birth and the pregnancy rates are as good in both, comparing letrozole to ovarian drilling. So letrozole, we have various protocols, and we can have this. Normally, we give 2.5 mg OD for 5 days, as we give clomiphene right from day 2 or day 3 to day 7. In the super ovulation protocol, where we use 5 mg, we give more. We give 5 mg from day 3 to day 7, and we see that the pregnancy rates are quite high. With the 5 mg letrozole, it is 26%. With 2.5, it is 6%. So with the super ovulation 5 mg, the pregnancy rates are higher. One can use it for 10 continuous days, 2.5 mg OD daily from day 1 to day 10, with resultant increase in pregnancy in the long letrozole group. Also, one can do a step up of the letrozole protocol. We can give on day 2, single tablet of 2.5 mg. On day 3, 2 tablets. Day 4, 3 tablets. Day 5, 4 tablets. So this is the step up protocol, and also this has been shown to give higher pregnancy rates. Single dose of 20 mg also can be given, which gives us a comparable pregnancy and a better endometrium. So these are the cumulative outcomes that were seen comparing the clomiphene and the letrozole. And here we see that the ovulation rate is much, much higher with letrozole compared to clomiphene, and the twinning is much lesser. Though side effects in clomiphene are hot flashes, here fatigue and dizziness is a problem with letrozole. The same thing being depicted with the bar diagrams. Now, comparing this in this meta-analysis and the systematic review, comparing clomiphene and letrozole for super ovulation in unexplained infertility undergoing IUI. So what does this say? This forest plot of pregnancy rate per cycle suggests that there is no difference between the letrozole and the clomiphene citrate group in cases of unexplained infertility. So one can try anything. Now, what are the international evidence-based guidelines on assessment and management of PCOS 2018 say? Can letrozole be used as the first pharmacological agent? They say yes, it should be considered the first-line agent, first-line treatment for ovulation induction in women with PCOS and an ovulatory infertility when you have ruled out other infertility factors. But where it is not available or it is not permitted, in certain countries it is not permitted, or where the cost is prohibitive, one can use other ovulation induction agents. So there was this scare and the fear that letrozole causes lots of congenital anomalies, it has adverse pregnancy or neonatal outcomes, but all this fear has been taken over by these articles that were there, and now it has been absolutely made clear that there is no increased risk with letrozole. Now, once this letrozole and CC, this combination fails, and when we have even added metformin, if it fails, then gonadotrophins can be considered as the second line of drugs. Can they be considered as the first line? Yes, that also the guidelines say can be considered, provided we have the expertise, provided we can monitor these women by intensive ultrasound. Where should we use the gonadotrophins, and why? What is the evidence says? Now, using gonadotrophin, low dose protocol should be used because the pregnancy rates do not differ from the pregnancy rate which result from a higher dose. The types of gonadotrophins: HMG, highly purified HMG, urinary, and so the impurity levels as they keep on going down, and in recombinant FSH we have no impurity. So the various types. What are the factors which affect the BMI? Because the dose is directly proportional to the patient's BMI. Ovarian reserve, AMH, AFC levels. If the AMH is high, we know we are dealing with a PCOS. AFC, we would be tackling that Dr. NM sir will be taking about this, the follicular monitoring and the endometrial thickness, how we monitor on ultrasound while we are dealing with these women. age of the patient, very, very important, the cause of infertility that we are dealing with, and very important, the dose that we've used in a previous cycle. So we should always go through the papers that this lady is carrying in her previous cycle. What was the dose that was given, and with what that means, with that dose, if she did not ovulate, whether we should continue using that dose or we should step up our gonadotrophin dose. And the usual starting dose is 75 in the conventional regime. So we have various regimes, the conventional, the low dose step up, and the step down. So conventional is something like we go to a restaurant or hum order karte hain shahi paneer and a makhani dal. So we know nothing, I mean, at least that was going to be good. So in a conventional regime, we are not going to go wrong. Everything is going to be fine. If we are not going by step down, step up, at least let's start with the conventional. That means we start with the 75-150 IU, start monitoring them by ultrasound, serial ultrasounds from day 2. And if our follicle is not growing more than 10, then we increase the dose. So some practitioners do serum E2 levels also, but basically ultrasound, one can monitor them by any of the two or both of them. So this step up is where we gradually increase the dose every 5 days, starting from 75, go to 150, and then 225. And this is actually more useful for the PCOS. Why? And the principle behind this is that we can find out the threshold level that will lead on to the monofollicular development, and we can then avoid OHSS. Now, here we have to be very persistent, because we continue using this dose for maybe days together, even 14 days, and this low dose step-up protocol can go on for 21 days or as long as even 28 days. And one has to be very patient in these patients. We start with less, 37.5, give it for 7 days, see the ultrasound, see the follicle. If it is more than 10 mm, continue. The daily dose is just increased by 37.5 till we start seeing the follicle reaching 18 mm. So here we start with 75, increase by very, very less amount, as minimal as 25 to 37.5. That means increase half a ampule every week till the maximum of 225, and maintain this dose till we have reached 18 mm. So this is more of a physiological, the step down now, that was the step up. Step down is more of a physiological thing, where we, in the natural cycle, where the balance is between the decreasing dose of FSH and the increasing sensitivity, which is responsible for the growth of dominant follicle and the atresia of the remaining follicle. So we follow the same sort of a thing, where we give a higher dose and then come down. So we start with 150 from day 2, and once we see 2-3 follicles are 10 mm, then we gradually decrease, and we continue with lesser doses till we have got good follicle. We have 2 follicles of 18 mm. Now, why we add CC gonadotrophins to clomiphene citrate? That means the sequential use has become an increasingly utilized method in patients who fail CC therapy. So where we have CC resistant patients or CC failures, we can, rather than straight away going to IVF, we can add along with metformin gonadotrophins, so that this becomes a little more cost effective treatment for our patients, and there are lesser multiple pregnancies and lesser OHSS. So in these cases, we give CC for 2 to 6, day 2 to day 6, and 150 units on day 6 and 8. I think Dr. Gautam was suggesting that we add, after CC, we start adding these gonadotrophins and continue doing our follicular monitoring. And if the growth is inadequate, we then add on right from day 9 our gonadotrophins. Now, what is the committee opinion regarding the use of exogenous gonadotrophins for ovulation induction in anovulatory women? That means gonadotrophins as the first line of treatment for ovulation induction in anovulatory. They say that the clinician should have requisite training experience. And our goal should be to promote a single mature follicle, though it can be difficult to achieve sometimes. And because a monofollicular development decreases the risk of multiple gestation and OHS, and the risk can never be completely eliminated with the use of gonadotrophins. We should counsel our patients right at the beginning before starting them up with gonadotrophins about the cost, about the risks of the ovulation induction, about the chances of multiple pregnancy, and that they need to come for follicular monitoring very often. Now, cycle cancel, we can start with the low dose and increase gradually, cautiously, because we want to go only for monofollicular developments. Cycle cancellation should be considered if we have more than 2 follicles of 16 mm, or if there are 3 or more intermediate size follicles developed. Now, luteal support is good for patients with hypothalamic amenorrhea, or where patients where we have used gonadotrophins in cases of stimulation. Now, which gonadotrophins? The guidelines say that one can use anything. There is no evidence of a difference in live birth and OHS between urinary derived gonadotrophins, between recombinant FSH or HMG. Now, so this is how we go: CC or letrozole for 4 to 6 cycles. No response. We've added metformin as well. Go on to gonadotrophins, go on for another 4 to 6 cycles. Either if the patient agrees to IVF good enough, or if we may also try laparoscopic ovarian drilling as well. Now, the various comparisons of the various clomiphene, metformin, CC with metformin, letrozole, FSH, LODs. So the pregnancies and the live birth rates are good with letrozole, as good as FSH. And with clomiphene, it is lesser. With LOD also, the pregnancy rates are 22%. So why should we use analogs? What are analogs, and why should we be using them? Analogs are routinely used in IVF cycles, but not routinely recommended in IUI cycles. And what are their indications for their use in IUI cycles is those patients where we have had premature luteinization or a premature LH surge while undergoing stimulation by gonadotrophins. In those cases, we would be adding GnRH analogs, or in patients who are PCOS, where they have high LH levels, and or there is any history of a similar premature luteinization. Also, in cases of endometriosis who require down regulation, we use GnRH analogs. Now, we have a long protocol where in the first, we have 2 phases. First is where pituitary desensitization is done in the first phase, and in the second phase is the stimulatory phase. So agonist is given in the previous cycle, in the mid-luteal phase of the previous cycle, 0.5 mg, continue till day 1 of menstruation, check for down regulation by doing the serum E2 levels, by seeing the endometrial thickness, and reduce the dose to half and start the gonadotrophins from day 2. After that, start the monitoring. Now, long protocol has the disadvantage in terms of duration and the cost of treatment. And there have been a higher risk of hyperstimulation and multiple pregnancies, high risk of cyst formations in these cases where a long protocol has been used. And the pregnancy rates are not significantly better than with gonadotrophin only protocol. Now, agonists, we can use a short protocol as well, where we start the agonist from day 1 of the periods, continue till the day of the trigger. Advantages, it is a shorter and less expensive treatment. Antagonists. So what does antagonists now have taken the first seat, or the prime, their concern, they are prime favorite of everybody these days, of all the infertility specialists. And why? Because they are like there's a shortcut to our treatments now with the antagonists, because the treatment duration becomes lesser, and these the antagonists act by competitive inhibition of the receptors and causing a rapid decline in the FSH-LH, and thereby we can take care of our premature LH surge. And we have various protocols where it can be started on a daily dose regime, or in a single dose, which is a French protocol, where we give only a single dose of 3 mg when the follicle is 14 mm. Whereas in the daily dose regime, it can be flexible when the gonadotrophin and the antagonists are started when the follicle reaches 14 mm, or it could be started on a fixed day right from day 6 of the stimulation, where we call it as a fixed regime. Advantages that it is very simple. It is relatively simple compared to the agonists, and because the effect is reversible, lower OHS, and the preserved pituitary response. So very good thing is that we can give the agonist as the ovulation trigger when we are using the antag cycle. So that is very, very important and very advantageous platform that we get while we use them. So we have various adjuncts. So LOD, when should we use ovarian drilling? Because it is a one-time procedure to induce ovulation, but in certain select cases, the women who are CC resistant, especially lean women, those who have very high LH, those who have high androstenedions, or if the patient is requiring a laparoscopic assessment of the pelvis when we are doing a diagnostic hysterolaparoscopy, and the patient is PCOS, after taking prior communicating, consenting, then we can do a laparoscopic ovarian drilling in these women, or if there has been previous over response to COH for IVF. Now, it should be done, the ovulation are good, 70%. Pregnancy rates very also good, 60 to 65%, similar to gonadotrophins. And but the thing is that it is a surgical procedure, and it should be done properly, and we should not be using it over enthusiastically, because it may lead on to premature ovarian failure. Now, we need to monitor our cycles so that we can time whether the patient is doing well, when she would need an ovulation induction with HCG, and whether there is no risk of hyperstimulation. We confirm ovulation, and that we can do with our sonography. That can be done even with E2 measurement or by LHSAs. And this brings me to the end of the talk nearly, because all this, when NM sir is there, I cannot, I should now, I think, close down. And the only trigger, the last slide is, when should we give trigger? When the number of when the lead follicle in clomiphene citrate is 20 to 22 mm, or in case of gonadotrophin, 16 to 18 mm. This is the time when we can think of ending our ovulation induction. And the number of follicles, we should be very, 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 it should be very stringent that if there are more than 2 follicles, more than 16, we should not trigger. Or if the follicles more than 12 mm, if they are more than 8, also we should not trigger, because such patients usually then would give us trouble. They would end up into multiple pregnancies. And we should also, the endometrium should be 7 mm. So that is a brief about the ovulation induction. Thank you so much.
Thank you so much, Jyoti ma'am. Now, may I request our esteemed commentators, Dr. Sharda Jan ma'am, may we please have your words of wisdom?
I think Dr. Jyoti has done an excellent job. She does not leave anything for the experts to say, but I will just make a few comments. I think initially she showed the success rate, which each and every gynecologist practicing infertility should know, that the timed intercourse is gynecologists are very fond of it, but it gives you a success rate of only 4%. When you do CC and IUI, it gives a success rate of 8%. When you combine CC or letrozole with the gonadotropins, it gives a success rate of 10 to 12%. And when gonadotropins with IUI used, success rate is close to 20%. When you're using it without IUI, the success rate is around 7 to 8%. So this must be remembered. If you're using such costly gonadotropins and if you do not combine with IUI, I think this is not done. So this is one thing. Second thing, I wish to just comment upon what she has said, that no pregnancy is ever going to occur in case if the endometrium is less than 7. So that particular part, I think the patient also must be told about this, that this is what is happening. She has also already said, I'm also a firm believer as far as the gonadotropins is concerned, no point giving more than 75 IUI in comparison to higher dosage. The pregnancy rate are the same. And as for the antag is concerned, I feel, antag should be kept for IVF cycles. IUI should be not complicated. It should be left very simple. And once she requires IVF, then we will definitely go ahead. So I'm not fond of using antag at all as far as the IUI is concerned. So I think with these things, monitoring is very important, which Dr. Narendra Malhotra is going to emphasize time and again, because gynecologists should do the monitoring themselves, not leave it to any outside person to do this particular thing. So with that, I think I have nothing to add.
Madam, what's your message to the gynecologist who claims मैं तो जो भी IUI करती हूँ pregnant हो जाता है?
IUI जो करती हैं क्या?
There are some gynecologists who claim whichever IUI you do get pregnant, 100% result है मेरा.
डॉक्टर साहब एक बात बिल्कुल क्लियर है.
This message has to go in that IUI success is not more than 20% anywhere in the world.
IUI is a success rate. If we are using oral ovulagens, it is not, and combined with the IUI, it is only 8%. And you can't go on and on and on. I am not in favor of giving more than 6 cycles of IUI. I feel the combined, if you are using it, again, it is 3 cycles they should use. But I think, if patient is young and if you want to be really serious about it, one should not hesitate using a gonadotropin cycle, which should be the last attempt with her. So you will come to
low dose stimulation, no high dose.
No high dose. And in IUI also success rate is not more than 20%.
So that's it. So that message has to go very clear to the people, whoever is on this. Please don't give over-promise with IUI. It is better than timed intercourse, but not 100%.
डॉक्टर साहब ये हमारी क्लिनिक्स में लगा के रखना चाहिए बाहर 2-3 जगह.
Absolutely, madam, I agree.
Yeah. Sonia ma'am, can we have your opinion?
Thank you so much. Moving a little ahead from what Dr. Madam has said. See, we are now moving on to letrozole as being the first line drug, from clomiphene. And we all want it. We all like it as a molecule. But what is still remains to be seen is what are the patients who don't respond to letrozole? We have no idea about letrozole resistance as yet. We have certainly found out what are the patients who are not going to respond to clomiphene. And that is also in addition to what Madam has said, that, there should be a limit, and what Dr. Malhotra has said, that there should be a limit to what we are doing. There should also be a limit to understanding, we have to understand this patient is not going to respond to clomiphene. So why put her through 3 cycles also of clomiphene? Right from the beginning, when the patient comes to you, a PCO, that, she's a resistant, you should be looking at her face and be able to decide whether she's going to be a resistant PCO or not. So that is what needs to be actually put across to all the gynecologists, because there has been rampant use of all these drugs. And that is not only somebody is talking on thin endometrium also, I think, and this is one of the rampant causes of thin endometrium. This consistent use of clomiphene, 1 cycle after another, doesn't give the uterus time to repair also after giving the letrozole and the next cycle comes on. So all those things have to be actually considered now. And it is time we moved on to gonadotrophins, like Dr. Sharda is saying. When you don't get good results with these oral ovulagens, what is the use of putting the patient through them again and again? So we have to actually learn to diagnose beyond just infertility and try and see what is the kind of patient that you're dealing with, and then put her through the ovulation induction. Thank you. Thank you very much.
Thank you so much, ma'am. Dr. Asha, ma'am?
I think most of it has been said. One good thing that I liked about Jyoti's presentation is she brought about the point of ovarian drilling and in which particular cases it should be done. So it does have a role if it is done vigilantly and in select cases and using the proper current and proper time. Because if it is done in right indication and you leave the patient for some time, even without monitoring, many times there may be spontaneous conception that would reduce the monitoring, the cost, and multiple pregnancy. So, but the selection has to be really apt. So that was a good point you brought up, Jyoti.
Thank you so much, ma'am. So moving on, next, Nakul, can we have Sir's CV slide, please?
I think you can leave the CV, no? Just.
All right, cool, sir.
Everybody knows, sir.
ताजमहल के सामने एक ताज रहता है, उसका नाम नरेंद्र मल्होत्रा है.
अरे नहीं, ताजमहल मत कवर मत बनाओ यार.
नहीं रहता है, कहाँ है, कवर नहीं बनाया.
आगरा में शिव मंदिर भी है.
अच्छा ठीक है, चलिए.
5 शिव मंदिर है, very good ones.
Oh my God, ये तो पता ही नहीं है.
Next time you come, I'm going to take you to all 5 of them.
Sure. One of our favorites, Professor Dr. Narendra Malhotra, sir. I welcome you, sir. Sir needs no introduction. He's been there and he's been teaching all of us and all my seniors too. I welcome you wholeheartedly, sir, and waiting to hear how to monitor ovarian stimulation.
Thank you. Thank you very much. Yeah, can I?
Nakul, can you please stop sharing your screen? Yeah, thank you.
So, ladies and gentlemen, very good evening to all of you. It's indeed a pleasure to be here on this ISAR platform talking about follicle monitoring. We're going to go back to basics and make it as simple so the gynecologists, the normal gynecologists should be doing it. And as put by Dr. Sharda, Dr. Sonia, the gynecologist should be monitoring and learning TVS. If you know how to drive a car with a flow shift gear, then what is there in TVS? You're looking forward and pushing the gear forward and driving. So that's how simple TVS is. And your mind should be open to what is there in the pelvis. So that is it. So my first questions are the quiz questions are follicle monitoring should start when? Day 2, 3, 4, 6, and 9. And you can put it in your chat box, and we are giving no prizes to the seniors, but we'll give a prize to the junior most. And then antral follicle are of the size 0.2 to 2, 2 to 6, 6 to 9, or more than 9. So these are my 2 quiz questions which everyone should be answering. We all know that the outcome of the pregnancy will depend on the embryo, and the outcome, the quality of the embryo will depend upon the oocyte quality. So a complete understanding of the ovarian follicle and dynamics is very, very important. And it is very important to monitor the entire cycle yourself so that you do not make a mistake on the dosing or increasing, reducing the dose. So a little bit of physiology. What happens first is that there is a follicular recruitment and there is a selection of a dominant follicle, and then the follicular growth under the FSH stimulation, and this follicle will secrete estradiol, which will have peripheral effects, especially on the endometrium. So the endometrium proliferates and there is an ovarian endometrial synchrony which happens. Then the follicle ruptures and it starts secreting progesterone and the luteal phase starts. And the endometrium becomes secretory, the implantation window opens, and if the embryo reaches the endometrial cavity at that time, you get a pregnancy. So how do we evaluate the ovaries? Ovary, you evaluate first for the size and site of the ovary. You have to see the ovarian reserve, the antral follicle count, a follicle, how many are there, correlate with the menstrual date and correlate with the endometrium. Push and pull the ovary to see for adhesions. Look for ovarian cyst, dermoids, endometrioma, tumors before you start ovulation induction. Where do we look for the ovaries? You look laterally. You pan the probe laterally. And if you cannot see the ovary, identify the ileal vessels. It is right there in front. Sometimes the ovary may be very high up and sometimes they be in the pouch of Douglas, depending on the adhesion. And then you do the push and pull sign. And you can identify the ovaries almost in 99% of cases very easily by TVS. A lot of people come and tell me left side ki ovary nahi dikhti because of the sigmoid. It might be difficult because of the gas in the sigmoid, but you have to look for it. Now, some of the structures which look like ovarian follicle are cross-section of the iliac vessels. So turn the probe right and left. Vessels around the uterus and ovary. Large Nabothian cysts have been reported as follicles. Hydrosalpinges have been reported as follicles. Bowel has been reported as follicles. Ovarian, small ovarian cyst, persistent para-ovarian cyst. All these have to be kept in mind. So mind has to be open. And if your mind is open and knows all these things, you will be diagnosed. Then we need to do the follicle tracking, as we call it, or a follicle monitoring. So first, which side? So destined to dominate and ovulate. We have to identify that. Timing, number of follicles growing, rate of growth, size of the follicle, and try to identify the cumulus so that you know which has an M2 oocyte. So the early follicular phase, cohort of follicles is up to 10. Selection of the dominant follicle occurs, or DF occurs on day 8 to day 10. Then it grows at the rate of 1.5 to 2 millimeters a day. And the dominant follicle will become 18 to 24 in a non-stimulated cycle prior to ovulation. So your baseline scan has to start on day 2, where persistent corpus luteum cyst, follicular cyst, PCOD, chocolate, endometrial shedding, antral follicle count has to be done. So you rule out all the pathologies. An antral follicle count is 2 to 9 millimeters. It's a reliable determinant of ovarian reserve. You count in both the ovaries and total them. Any follicle over 9 is not counted as antral follicle. Okay. Small antral follicles 1 to 6, selectable due to responsiveness of gonadotrophin, and larger antral follicles more than 6 are gonadotrophin dependent. So that is how we make the which follicle will respond to gonadotrophin. After day 2, we can go straight away to day 6. Day 2, you can start the letrozole or clomiphene or the gonadotrophin stimulation, whatever. And then you assess the response. So ideally on day 6, you should be having 6 follicles if she's responded to stimulation. If it is normal cycle, then 1 or 2 will be dominant, and this will be 10 to 12. And you'll start getting an endometrium, which is triple layer and about 6 millimeters. And your dose adjustment can be done here. Then day 9, we go again on day 9. And day 9, you see for the follicular size, the numbers and the mean diameter would be around 16 to 17. And the endometrium should come to about 8. So if it is a gonadotrophin stimulated cycle, 17 would be your HCG trigger. So HCG trigger would come on day 9 or even day 10. So your ovulation occurs on day 12 or your IUI is timed on day 12. So please don't get scared that the follicle has become already 17 on day 9. It is destined to become 17 if you are gonadotrophin stimulating it. How do we measure it? If it is circular and the same person doing, 1 diameter is enough. If it is oblong, many of them, then 2 diameters and take the average. And then you see the endometrium, and so you have to see the follicle endometrium synchrony. Follicle is growing, endometrium should be 3-layered. If it is thin endometrium, that means either that follicle is not producing estrogen or the endometrium is not responding to the endogenous estrogen which the follicle is producing. Now, I've seen that a lot of people add estradiol to the stimulation from day 2 only with clomiphene. Remember, clomiphene is anti-estrogenic. It is blocking the endometrial receptors to estrogen. So if you add estrogen, where will it work? It will not work. So estradiol, please don't give it with clomiphene or letrozole. It doesn't work. They are both blocking the receptors. So that protocol has to be abandoned, whoever is using. Then with 3D, we can make out where the cumulus is coming. That's a cumulus in a 2D. And if you get a 3D, then the cumulus identification. So is there going to be a difference between CC and gonadotrophin cycles? Yes. CC cycles are these. One is big and the rest are small. Gonadotrophin cycles, the cohort, all of them grow at the same size. So that is the difference. Then with 2D, if it is getting hyperstimulated, then the number count may be difficult. So you might get difficulty in counting how many are there and looking in. So we can do the ultrasound niche mode, or you can do the volumetric measurement. And that is what we call a sono AVC. Now or you can do the volume tools like this. So you can see in the ovary, and here you see they all get colored, and below threshold and above threshold, the machine automatically calculates the volume and tells you the number of follicles. So sono AVC or sonograph based automatic volume count is very, very good. We still don't have tables or values for volume to give HCG, but it will tell you how many big follicles and how many small follicles. So that is the advantage of doing a Sono AVC. Again, very simple, no big deal. You just put it on the ovary, press the Sono AVC button on your machine, 3D. Everyone of us should be doing 3D now. Easier than doing a 2D because the machine is doing your work and you're not doing. You just have to focus it in the right place. Then we need to do color Doppler in all follicle monitoring. So color Doppler will show you that each follicle will develop vessels all around. And that is what is known as intrafollicular blood changes and perifollicular vascularization. Now for ovary, the ovary has an extrinsic supply from the uterine artery from the aorta and one from the tubal artery from the uterine. And then this enters the hilum and breaks into helical spring-like arteries. So in the hyphae, and that is a microcirculation. When the follicle grows, the vessels straighten and allow more blood to go. So in PCOS, when there are too many follicles, too much stroma, these helical arteries will not straighten up. So they remain high resistance. And that is what is a resistant PCO. If they have more blood in PCOS, more blood is going and these all helical arteries have opened up, that means it's going to be hyper responsive PCO. So we can make out and then we can decide whether she needs a laparoscopic drilling or not. So it's a high pressure system. It's a coiled helical system. The theca complex, fundamental unit of the follicle and granulosa. Normally it should be high resistance. The resistance will fall when the intra-helical arteries straighten up with the follicle growing. And then you'll see all around also the vessels. So if the resistance is not falling than 5, what do I mean by resistance? See, when a heart beats, you get a systole, the blood will go forward. When the heart stops in diastole, the blood should still go forward depending on the vessel musculature. So about 50% of the blood as compared to systole should go in if it is physiologically the follicle is ready or endometrium is ready or pregnancy, umbilical artery. If it remains high resistance and only 20% is allowed, is going as compared to systole, that means RI is 0.8. So that is high resistance. So that's how we can look at the wave and do. So perifollicular vessel is very important, and 75% of the follicle, if it is vascularized, will give you an M2 oocyte. So that's how we can make in IVF cycles, how many M2 oocytes we are going to, we can predict that. So we can predict, and let's see, look at this vessel here in the intra and the resistance. See, the diastole is 50% of the systole. So the resistance index would be around 0.5. That is good enough. So this is very, very good vascularized follicle. And when we did a power Doppler, we saw that whole vessel, whole follicles. So this is the kind of vascularity which changes occur. So perivascular follicular blood flow need to be looked at before opening. Now, someone was saying PCO, how to decide. I told you already, if it remains high resistance inside the ovary, resistant PCO. If it remains low resistance, that means a lot of blood is going. It is hyper responder PCO. So simple to do it. It takes exactly 1 minute to decide whether this PCO is going to be high resistant or it's going to be a hyper responder. Now this is high resistance. The diastolic blood flow is just 10% of the systole. So the resistance is 0.9. RA would be around 0.9. By looking at the wave, I'm not telling you to calculate. Just look at the wave. Please look at the wave and do it yourself. Just a button. And then if there is too much stroma, of course, the drilling is because just Dr. Asha said, correct current, correct dose, and correct number of holes, 5 to 6 holes, and not burning and charring like this. So this has to be done. So PCOS, we can predict which PCOS will go into OHSS so that our stimulation could be. So we can predict the risk factors if by color Doppler, if that PCO is going to explode. And if you see too many follicles and you see too much blood, and we can do it by Sono AVC also. You see that the antral follicle count here is 24. So this in each ovary. And if it is 12 also in each ovary, it's hyperstimulation. And of course, the new ART law says that you cannot stimulate an ovary to get more than 7. How we are going to do that? It's beyond me. When ovulation is going to occur, the walls of the follicle will go inside. The granulosa separates and you see blood here. or you see. So at 16 to 17, we will give HCG in HMG cycles or FSH cycles, at 18 to 19 in clomiphene or letrozole cycles, and in normal at 20 without any ovulation. That's how we decide on the HCG timing. So only size is a poor predictor. You have to look at double contour, you have to look at crenation, and you have to look at cumulus to predict ovulation. And peri-ovulatory signs, double wall sign, appearance of cumulus, vascular, signs of ovulation, it will disappear, it will collapse, there will be fluid in the pouch of Douglas, and there will be blood-filled fluid in the follicle. It will refill with blood, so you'll see echos inside. And then you'll see that the corpus luteum starts appearing, the blood flow again comes in, and you see, if you see a good vascular corpus luteum after 48 to 72 hours of ovulation, no need to do luteal progesterone levels and all. This is not going to be luteal phase defect. So good corpus luteum like this, variegated appearance with good color flow all around, and will tell you. Luteina is an unruptured follicle. The follicle will not rupture and keep on growing. There's no free fluid, and internal echos will come inside. So no signs of ovulation, and the follicles keep on growing with internal echos. And here, when you do up progesterone levels, it will rise to a little bit, but not as a luteal phase. So luteal phase and the window of implantation, again, you can predict by a good ultrasound color Doppler of the endometrium and of this. Lastly, because of COVID time, it has taught us that the ART and follicle monitoring should be patient-centric. Unfortunately, it is not there in India. Indian women will not take self-injections like this and will not do self-monitoring of themselves. But this, the self-operated endovaginal telemonitoring is the future, especially in epidemics like this, where the people can take their injections and monitor themselves, and we can just guide them. So self-operated endovaginal telemonitoring is a probe which is given to the patient to take home, and she lies down with legs spread, puts the probe in and points out to the ovaries. The picture by telemonitoring comes to us on our computer, and we measure it, and we can just tell her to adjust right and left. We measure the follicles and we titrate the dose from home and titrate. So that is how it is. The telemonitoring through the internet, automatic images come to the patient is here through our PC, through internet, comes here, images analyzed, physician guides, and so it is very, very advantageous. You get access to rural, you get access in epidemics, direct treatment without any intermediaries, no loss of time, energy, money, ecological advantage, less petrol spent on coming to the hospital. Patient and our partner both can actively participate in the treatment, and active participation of reproductive nurses who can go home and do this monitoring. And we will have improved quality of follicular growth. And so discretion of treatment. The patient doesn't want to tell anyone, so she can monitor at home. So this is the paper original article which came out in 2009 on patient acceptance. It is still not in India, and I feel very soon we should be moving towards SOET and self-operated endovaginal telemonitoring for it. So ladies and gentlemen, thank you very much for inviting me here, and I hope I have simplified how to monitor and how to decide the protocols, especially in PCOS, high resistance, and OHSS. Thank you very much, Dr. Jyoti Malik, and all the best to all of you who are fighting elections. I think there was some problem in the voting today because the pictures getting mixed up, so the voting will restart again tomorrow.
Thank you so much, sir.
Thank you so much. Yeah, please, Jyoti ma'am.
No, it's okay. We will take the comments from Dr. Sharda Jain ma'am and all expert people. Dr. Sharda ma'am.
I think, after Dr. Narendra Malhotra today, I don't have even one single sentence to say. So that's what it is. Thank you very much.
Dr. Asha ma'am.
You are an inspiration, Dr. Sharda. You are an inspiration to many, including me.
No, Doctor. I find my partner is trained by you, and she is so meticulous. She's so meticulous as far as monitoring is concerned that I'm absolutely at peace always.
Let's say we belong to the Mutual Administration Society.
Asha ma'am, your comments, please.
Excellent talk, Dr. Narendra Malhotra. One thing I wanted to ask is many people want to know what sort of machine they should be having, and should they be having machine with this Sono AVC, this volumetric thing, and how practical it is, because particularly I have, but I've never used it since last 10 years or maybe more, but I've never used it in day-to-day practice. So what is your opinion on that?
So if you are an IVF specialist, if you are an ART specialist, see now 3D machines are coming within 15 to 20 lakhs. So it is very, very affordable. What was not affordable, and you get all the attachments in under 20 lakhs of, and it takes 2 or 3 extra minutes to, Dr. Asha, try to press the Sono AVC button, and I promise you, and try to put in some saline to do the cavity 3D. You will forget doing hysteroscopy, and you will forget doing any other monitoring. You will get addicted to it. Just 2 extra minutes that machine takes. So I think it is well worth for all infertility specialists, at least IVF specialists, to invest in 3D, and a common gynecologist to at least have color Doppler. A basic color Doppler machine is under 10 lakhs now. So everyone can afford it. And it will help you a lot in obstetrics if you have an obstetric practice.
True. Thank you so much.
Yeah, thank you so much, sir. It's really overwhelming, listening to you every time, and you take out time from your precious schedule and teach all of us. Thank you so much. So moving on, we have another eminent speaker with us, Dr. Jatin Shah, sir. Sir, I welcome you. Nakul, can we have sir's CV, please?
Sharing, doctor.
Yeah.
And
yes. So I guess everybody knows Dr. Jatin P. Shah. He's the director, Mumbai Fertility Clinic and IVF Center. He's helped establish more than 20,000 IVF pregnancies over 3 decades of ART practice. He's pioneered the setup of IVF centers and practice of batch IVF 25 years ago. More than 500 international and national presentations, keynote, guest lectures, webinars. And I guess we've all learned from him so many times. And numerous awards. Sir, there is so much to introduce you. I'm really feeling honored to do that. I welcome you, Jatin sir, and I don't want to waste any more time. I actually want to learn from you. So what do we do with hypo responders? Thank you, sir. Over to you.
Thank you, Yukti. Thank you, Jyoti. Esteemed faculty, senior members, dear friends, and delegates. Of course, it's a pleasure to be here today. I'll just... So, it's very interesting that in the midst of this pandemic that we've all been fighting for the last 2 years, we have another epidemic brewing in our own ART field. And that is the epidemic of hyporesponders and poor responders. And we really find that why is this topic becoming more and more important to us now? And it's because, if you would agree with me, when we look at our IVF practice with self-oocytes, you would agree that almost 50% of our patients today fall in Poseidon's 1, 2, 3, or 4. And what are these 4 groups of poor responders? We know that groups 1 and 2 are young and old patients who started with a normal ovarian reserve, but did not respond adequately and the way we would love them to. They are the unexpected category, which takes you unaware. And of course, you have the expected groups of Poseidon's 3 and 4, who are young and old patients who start with a low ovarian reserve and are expected not to give you too many oocytes. But if you are talking of this huge chunk, no wonder this topic always takes precedence at any meeting. Before we move on to actual management, does the number of oocytes that you retrieve really affect pregnancy rates? And we all know Sankara's classical study that the best numbers to get pregnancies in fresh embryo transfers is 5 to 15. That means more the oocytes you get, the higher will be your pregnancy rates. But what is the more recent evidence? And here you can see from 2019, clearly a huge study, almost 300,000 IVF cycles, that the group with the most oocytes aspirated had the most top or good quality day 2 or day 3 embryos. And that brings us into a debate on mild ovarian stimulation. That is it okay to get just 1 or 2 oocytes and expect the same pregnancy rate? And you can see this study here from 2020, which clearly shows that to get 1 top quality embryo, you need at least 3 mature oocytes. So if you want 2 top quality embryos, you need 5 oocytes. If you want 3 top quality embryos, you need 5 or 6 oocytes, and so on. So the more the number of mature oocytes you get, the higher will be the number of top quality embryos. So it's not enough to just get 1 or 2 oocytes and expect a good outcome. Does a patient with a reduced ovarian reserve also have higher aneuploidy rates? Fortunately, it doesn't, especially the young group, that is Poseidon 3, which is young patients with a diminished ovarian reserve, which seem to be pouring into all our clinics every day. And this is some bit of good news for them, that although they have lower live birth rates, these are because of fewer oocytes and not necessarily because they have poor oocyte quality or a higher rate of aneuploidy. So for this group, maybe embryo accumulation is a good tactic to use in management. In management, does getting one extra oocyte really have a significant impact on outcomes? And classical study from 2017, you can see with every additional oocyte that you get, there is a marked increase in the live birth rate per cycle. So it's very important to try and get as many metaphase 2 oocytes as possible in poor and hypo responders, and also make sure that each of those try and get a top quality embryo for freezing or for transfer. What about iatrogenic poor responders? We know that prevention is always better than cure, and that is why don't underdose. When you feel, oh, she's thin, she's a normal responder, she has a good AMH, let me use just 100 or 150 IU of REC FSH, which is more potent than the conventional HMGs, but you will quite often end up with converting a good normal responder into a so-called Poseidon 1 or 2. And this is what happens. You can clearly see here that you get significantly higher number of oocytes with 200 versus 100 IU, and so also with 200 or 225 versus 150 IU. So 225 should be your standard minimum starting dose across all groups of patients, whether they are normal, poor, or high responders. Coming then to managements of Poseidons 1 and 2, the commonest reasons here, of course, you have to understand is that you started with a low dose. So all you need to do is step up the dose in a subsequent cycle. Asynchronous follicular development. I keep talking about this in all my lectures because somehow people don't take it very seriously, but it's the most important aspect of good management in Poseidon 1 and 2, because they're just going to give you, say, 5 or 6 follicles. And if one has shot ahead and become dominant and the others are lagging behind, which happens in almost 30 to 40% of antagonist cycles, you will end up with a lower harvest of top quality embryos. Of course, the triggering, which is important, and most important when we talk specifically of hypo responders. Now, of course, I know I was given the topic hypo responders, which I assumed also meant poor responders. But if you go by classic definitions, hypo responders are those patients who have stagnant follicular growth after 5 or 6 days of gonadotropin stimulation. So you scan on day 7, all the follicles are at 10 to 12 mm. You scan on day 12, they are still stuck at day 10 to 12, and they consume huge amounts of exogenous gonadotropins. Then you keep pumping in higher doses of FSH or you add LH. And finally, after 17 or 20 days, the follicles are ready. And these are the ones where genetic factors, especially presence of polymorphisms, is very important. There was also some concern that if you go too high with gonadotropin doses, you will increase aneuploidy rates. Does this really happen? And that is why you don't need to have knee-jerk reactions of doubling your doses. All you need to do is increase the dose of FSH in the second cycle by 50 to 75. So you can see if you had given 225 and you did not get an adequate response, you increase to 300 and you will see a significant increase in the number of oocytes that you get. Coming to aneuploidies, a classical very recent study of embryonic aneuploidy using 150 REC FSH versus 300 REC FSH, and clearly you can see there is an increase and not a decrease in the percentage of euploid embryos. So higher doses do not increase aneuploidy rates in embryos. So this study clearly showed that it does not support the hypothesis that higher doses of gonadotropins results in a reduction of the proportion of euploid embryos. And coming to the most important take-home message for today, and just please do some form of pretreatment, especially in your antagonist cycles, so that all your follicles are of the same size. If you start on day 2 evening or day 3 morning or day 3 evening, you're too late. The dominant follicle has already been recruited, and invariably we will find on day 7 that one of them has shot ahead to 14 or 15 and the others are lagging behind at 11 or 12. And pretreatment is so simple to do. Either you use luteal phase estradiol or you can use norethisterone. If at all OC pills, just 10 days max, not more than that. But the best and the easiest and what gives the best outcome, especially for egg donors and even for patients, is the use of the antagonist on days 2, 3, and 4. So just give her the antagonist day 2, 3, and 4. Many a times the patient says, oh, I can't come on day 2. I have to go to work. I just got my periods yesterday. Can I come on day 3? And we say, yeah, it's okay. All you need to do is at the time of the first meeting, if she's committed to an IVF cycle, just pack the 3 cetrorelix for her and tell her that even if you can't come, please take these shots on day 2, 3, and 4, and then report even on day 5, and that's fine. And what is the advantage? You can clearly see with the pre-treatment, you get a significantly higher number of oocytes in these patients because you have a uniform cohort. And this makes all the difference between success and failure. What about the agonist protocol? We all just dumped it, that it is no good and it causes hyperstimulation. But isn't hyperstimulation what you want in these poor responders? You want them to go from 4 to 7 or 8 oocytes. Also, we all agree that with the agonist, and as Naren also showed, you have a synchronized follicular development. You don't have one follicle shooting ahead. What about direct effects of the agonist and antagonist on oocyte quality? And you can see here in this study, agonist, you have higher number of oocytes, lower number of oocytes with cytoplasmic abnormalities. You have higher number of fertilized oocytes and higher number of oocytes with normal pronuclear morphology, giving you higher clinical pregnancy rate. And yet somewhere, just because of the fear of OHSS, we just discarded the agonist and started using the antagonist protocol across all groups of patients. So we need to individualize that agonist could still be a first choice protocol for poor responders to get uniform cohort. And this is what is a big advantage in poor responders. And you can see here our own study. In the same patient, we did 1 antagonist cycle followed by 1 agonist cycle with the use of HMG or some form of LH from the beginning. Clearly, you get higher number of oocytes. And this is the best controlled study because you're comparing the 2 protocols in the same patient. And you have a higher proportion of top quality embryos. 30% versus just 17.5%, and that is the most important difference for pregnancy rates. What about hyporesponders? Of course, we know that these are usually because you saw maybe 12 antral follicles, but you ended up getting only 4 follicles, and that is the meaning of a hyporesponder. Or as I told you earlier, the follicles become stagnant. Most often, they are carriers of polymorphisms, sometimes oxidative stress, and rarely environmental contaminants. And here you can see LH beta subunit variant associated with increased FSH consumption. The GG homozygous shows higher resistance to FSH stimulation than GA. GG has increased basal endogenous FSH levels compared to GA. All these suggest impaired FSH receptor function when you have these polymorphisms present. Also, with the A allele, you see a huge ovarian resistance, which is why they require a higher consumption of exogenous gonadotropin. So again, the argument is that if you don't want to spend money, time, energy on testing for polymorphisms, why not just start with a higher dose of 225 to 300? So you cover those 15% of patients who would have polymorphisms, or you could also add LH, which if you know that she is a case with a polymorphism, it's best to add LH right from the beginning of stimulation so as to avoid the hypo response. Of course, there are studies on various environmental contaminants too, but the main point is oxidative stress, which might influence the quality of the oocyte. And here, especially in hyporesponders, myoinositol and even coenzyme Q given for 2 months preceding the IVF cycle in Poseidon's 3. Because see, in Poseidon 1 and 2, they were unexpected. So you didn't give them any pre-treatment. You didn't know they are going to be poor responders. But in groups 3 and 4, you can always do 2 months of pre-treatment so as to get a higher number of oocytes and higher number of top quality embryos. Management of 3 and 4, again, studies have shown that purely because of better synchrony and those 2 or 3 extra oocytes, the agonist protocol could be more effective. And you can see here live birth rates almost double of that of the antagonist in this study on Poseidon group 3, that is young patients with a low AMH or AFC. Now, what about higher doses of FSH in Poseidon's 3 and 4? Now, in 1 and 2, we know that you can increase the dose and expect more oocytes, but these are groups who don't have more oocytes. So even if you go to 300 or 450 or even 600, you're not really going to achieve any difference. If she has only 2 follicles, you will get only 2 follicles. And therefore, maybe 150 should be a standard dose, or maybe 225 at the most for a higher BMI or an elderly woman, to make sure that you get those 2 or 3 follicles in the right manner. LH supplementation, of course, we know elderly women all should receive it from day 1. Hyporesponders, if you know she was a hyporesponder in the previous cycle, better to start from day 1 or at least add from day 6 or 7. And there was a controversy that do poor responders benefit or they don't benefit. But the same groups have now shown that you can expect a relative increase in the pregnancy rates with the addition of LH from the beginning. So elderly women, whether to start LH from day 1 or from day 6. Clearly, day 1 has a huge benefit in terms of pregnancy rates as compared to day 6. And a more recent study corroborated these findings, where they divided the patients into mild, moderate, and severe poor ovarian responders. And luteal LH supplementation has a significant effect on increasing cumulative live birth rates in both moderate and severe poor ovarian responders. Coming to the trigger, which is one more cause of not of having a hypo response or a poor response, it's in a different way. Poor response just doesn't mean getting less oocytes. Sometimes you have more follicles but get less oocytes. Sometimes you have more oocytes but you get less metaphase 2s. Sometimes you have adequate metaphase 2s but you end up with less top quality embryos. And that is why the dual trigger is so important, because in nature, there is a release of both FSH and LH in natural cycles. When you give an HCG shot, you are only mimicking the LH peak. When you give a dual trigger, that is the agonist trigger, it induces a more physiological peak because it causes both LH and FSH surges. So you can see patients who had lower number of oocytes compared to the follicles that you have, the minute you switch to the dual trigger, we have a significant improve in all the outcomes. Also, patients who had a lower proportion of M2 oocytes, again, you see significant improve in all the outcomes when you use a double trigger instead of just HCG. And even in poor ovarian response, which is the topic for today, you can clearly see when you give recombinant HCG with 0.2 milligrams of triptorelin, you have a significant improve in all the outcomes which are concerned with this particular difficult group. What about mild ovarian stimulation? We keep hearing of mild stimulation protocols and so on, and you can clearly see the biggest problem is the number of oocytes, because with mild stimulation, you might end up with just one, as this study showed, whereas conventional stimulation, even in a poor responder, on an average would give you about 2 or 3 oocytes. And this study again showed that if the antral follicle count is less than 3, then maybe mild and conventional would be similar. But for any poor responder who has an antral follicle count of 3 or more follicles, mild stimulation will not give you as good an outcome as a conventional stimulation protocol. What about converting to IUI? Many times I get files where, oh, my IVF was converted to an IUI because I had only 3 follicles. There is no justification for this. And there are studies to show that if you have 2 or more follicles, you should not convert it to an IUI and just continue with the IVF, and you will expect a much higher pregnancy rate than IUI. What about any light at the end of the tunnel for these patients, especially with all the new laws coming in and oocyte donation becoming so difficult? We have to rely now on more and more methods of doing better self-cycle, even in poor responders, and giving them the optimal outcome. So dual stimulation, by conjugating a follicular phase and luteal phase stimulations, allows to maximize the number of oocytes. The biggest advantage here, more than scientific, is the psychological one, because you have already committed the patient to 2 stimulation cycles. And this was shown in this study by Ubaldi, who was one of the pioneers of dual stimulation, that the biggest problem when he compared dual stim versus conventional stim was that only 17 patients who were not pregnant out of the 100 who started the study with conventional stimulation returned for a second stimulation after the first attempt. So there's a dropout rate of almost 81% when you do conventional single stimulation, as against dual stimulation, where you commit the patient to 2 stimulations in 1 month, and therefore your cumulative live birth rate doubles from 7 to 15%. And here you can see significant improvement with luteal phase stimulation, number of oocytes, blastulation rates, number of blastocysts. And this, of course, was a more recent paper from 2020, where again he showed luteal phase stimulated embryos give a much higher pregnancy rate per transfer of almost 47%, as against 26% with the use of follicular phase, which would be similar to conventional stimulation protocols. Our own experience initially was really good. And you can see again, luteal phase stimulation did much better in terms of pregnancy rates and ongoing pregnancy rates as compared to when you use just follicular phase stimulated embryos. Of course, there are some challenges that do we need the antagonist in the second half? Can you use MPA throughout to prevent the premature LH surge? What should be the interval between the pickup and the second stimulation? What is the ideal trigger, and so on and so forth? And I'm sure with all of us doing more and more of this, the answers will be there in the near future. Adjuvants, of course, current evidence on the effectiveness of DHEA is rather low and therefore does not support its routine use, but transdermal testosterone treatment for 3 to 4 weeks, a lot of studies now showing definite improvements, and you can see here so many studies showing improvements in live birth rates, clinical pregnancy rates, number of oocytes, and so on. And we are still waiting for the ideal, whether it should be 20 days or 60 days pre-treatment, how much of testosterone, and so on. Interesting combination here, you could use letrozole again with gonadotropins. If you start 5 milligram letrozole from the first day of stimulation until the day of the trigger, you can see significantly reduced E2 levels, which is good. If you're doing fresh embryo transfer, you don't get supraphysiologic levels. You get higher number of oocytes, higher number of metaphase 2s, higher number of top quality embryos, and a very good clinical pregnancy rate with this combination. Growth hormone came with a bang, still not enough evidence all over the world. And this was Robert Norman's huge meta-analysis here, published 2019, clearly showed 130 patients, no significant difference in live birth rates with the addition of this expensive growth hormone during stimulation. Oxidative stress, again, coenzyme Q, lot of papers now showing 2 months of pre-treatment for Poseidon's 3 and 4 gives a definite improvement in most of the outcomes which are important for a take-home baby. And even more recently, in 2017, we had a study that the use of myo-inositol for about, say, a month or two before the egg retrieval, you can see that the oocyte and embryo quality and clinical pregnancy rate were better. Abortion rate was significantly lower. Proportion of grade 1 embryos significantly higher, and proportion of GV significantly lower in the myo-inositol group. And also you required significantly less total dose of REC, FSH, and gonadotropins with myo-inositol pretreatment as compared. And this is not PCO group. This is, we are talking about poor and normal responders. We all know about myo-inositol in PCO. So this study was specifically for non-PCO patients. Finally, laboratory essentials. Of course, classically, everybody was taught that elderly women do ICSI, less oocytes do ICSI. Is there any justification for this? And unfortunately, there is not. Even in the elderly patients, you can see here, conventional IVF will give you better number of zygotes, higher blastulation rate, and better live birth rates than doing ICSI for all. So please don't assume that if you get fewer oocytes, you need to do an ICSI. ICSI has a lot of problems. There is a lot of studies showing that it is not superior to IVF, even if it is the same. No proven benefit in poor responders and elderly women. What about PGTA? Again, PGTA will not increase the live birth rate, but will eliminate your miscarriages and aneuploidic embryos, of course, at the cost of much higher expenses, higher workload for the IVF lab, and so on. What about a link between diminished reserve and early miscarriages? None of us thought of this. When we have a lecture on recurrent miscarriages, we never talk of low AMH levels. And now we have evidence that maybe there is a link between the two. And you can see here this study from 2016, the recurrent miscarriage group, FSH more than 11, basal FSH 18.3% of patients as compared to just 4%. Very low AMH levels again in almost 20% of patients with recurrent miscarriage as against just 5.79% in the control group. So we need to consider this. And again, this huge meta-analysis here showing a 2.5 times odds ratio, higher risk for recurrent pregnancy losses with low ovarian reserve, low AMH, and low AFC. So there's a definite correlation between the two. The future, of course, is quite promising. We know, we all hear more and more about activated PRP injections into the ovaries. And this was the first study of 4 patients where they showed an increase in serum EMH, decrease in FSH, and they could retrieve as many as 5 oocytes in these very poor, almost menopausal patients where this PRP injection was done. Of course, they said additional research is needed, and we have now more and more papers coming in. Clinical pregnancy rate, live birth rate 33 and 40% in the PRP group as against 10 and 14% in the control group. So there are a lot of things on the horizon for the poor responders. And if all fails, of course, the more easy way out used to be oocyte donation. Of course, it's not going to be any more easy way out with all the new laws coming in, but still it would remain a last resort for most of these patients. And of course, finally, prevention is better than cure. If many of these women would have frozen their eggs at a young age, maybe they would not have been poor responders in the future. And therefore, it's our duty to counsel all the young girls and the young women who want to make careers and settle down late in life as far as family is concerned, that it might be wise to have their eggs frozen in a good bank. So with that, I come to the end of the talk. Once again, thank you, Jyoti, for inviting me here today, Fertility Forum India, and of course, Team MCure for always doing such a brilliant job. Thank you so much.
Wonderful, sir. I mean, you're a wizard. I mean, every time we listen to you, just we ऐसे ही देखते रह जाते कि अरे something new, more. Last talk also, even if it's the same, still there's so many things new to grasp.
I'm going to break some record of having given this talk. I've lost count how many times now.
But still, it is new to us. Thank you very much for joining and for sharing your knowledge and for revising such complex things and making them so very simple. So thank you so much. And from commentators, I would ask now invite Dr. Sonia ma'am to please comment.
Thank you very much again. Astounding presentation. Thank you, Jatin. It is always a treat to listen to you. And just a little question: what is your protocol for the day of transfer in these patients? Are you sticking to the blastocyst, or are you doing the cleavage stage? What are you doing for these hyporesponders and responders? Because the number of embryos is very few.
Yeah, so I normally have never been a big fan of blastocyst cultures, and I don't do fresh transfers for any of these patients. So it's always a frozen transfer. So whatever, even the 10-20% difference of endometrial receptivity, although they don't have supraphysiologic levels or whatever it is, but still somehow I feel that the frozen transfer does much better. And especially if you're doing embryo accumulation, you want to do 2 stimulations, or if you're doing a duo stim where you can't do a fresh transfer anyways. So my personal thing is to freeze on day 2 and do a day 3. That is first choice always. Because they give very few sites. I don't want to, just, always have that doubt. Oh, if suppose I would have transferred early, if you don't get a blastocyst, then to answer to the patient and all becomes very difficult. So I stick to day 2 and then day 3 after thaw. Occasionally, if they have more embryos, in which case they wouldn't be poor responders by definition, but suppose she has 8 or 10 embryos, then of course, in the second round, if the first day 3 transfer has failed, then in the second round, I would do a blastocyst.
No, especially I'm asking you because if you do accumulation, you do you are accumulating the embryos and you do end up with 10. Would you like to still go on to blastocyst, or would you still prefer the second, third?
I would prefer the second and
Thank you very much for that.
Unless she's elderly and insisted on PGT or something, which has a rarity, very few patients. But if at all, occasionally, otherwise I stick to day 2, day 3. I know, and now there is a lot of European research which is coming in, clearly saying that cleavage stage is better than blastocyst.
Absolutely.
It's all on a U-turn. So, it's always important that we use our own experience rather than just keep blindly following a random paper here and there. Okay, just because a patient has read on Google, oh, why you didn't do blastocyst, doctor? You have to have the answers and the references ready on your desktop to show them. Okay, that's not necessarily correct. And this is what is time tested and works well.
So, Dr. Jatin, I purposely asked you this because I wanted everybody to really know this, because everyone these days is harping on blastocyst transfer, which doesn't make sense at all. And you very rightly pointed out the agonist protocol as well, which has also been abandoned by most of us. It has its own advantages, and definitely, your selection of the protocol is very important. Every stage is important in IVF to give good outcomes. Thank you so much for this. Thank you very much.
Thank you so much. Thank you.
Thank you so much, Sonia ma'am. And thank you so much, Jatin sir. Shall we move on, Dr. Jyoti?
Yeah, I think Dr. Asha and Dr. Sharda, I can't see. So, and Dr. Jaideep sir has joined. So I think we can move on with now. Actually, sir,
as it is, there is a flood of webinars today, so probably they have another one to catch up. Yeah. So never mind, we'll move on. Nakul, can we have the CV slide? I welcome you, Jaideep sir. We all know Dr. Jaideep Tank very well. Sir is the Secretary General FOXI from 2018 to 2021. He was the project lead FOXI USAID project started in 2020 till 2024. He's the past president, Mumbai Obstetric Society, and so many things to sir's name. Oh my God, sir, actually, there should be a booklet to introduce you. It's a pleasure. So without wasting more time, I would want to listen to what sir has to say about the trickiest lot, that is the hyper-responders. Over to you, Jaideep sir.
Thank you, Yukti. I'm actually traveling between Bangalore and Mysore. So at 2 o'clock late last night, I recorded the talk and sent it to Jyoti. So I'll ask Jyoti to please play it, and I'm around to answer questions. But I didn't want to take a chance because I thought if the network is unstable on the highway, I would rather record it and send it. So Jyoti, if you could please, thanks.
Yes, sir. So nice of you, sir. Yeah.
It's indeed a pleasure and a privilege to be a part of this absolutely wonderful webinar by the Fertility Forum India.
Nishad, can you
congratulate the facilitator, Dr. Jyoti Malik, for putting together such a fantastic program. It's one of those rare blends of programs which is very relevant, has got absolutely brilliant faculty. I'm not only saying that because I'm there as part of the faculty, and also absolutely lovely topics with perhaps the best expert commentators that one could get. I must acknowledge the presence of the expert commentators, Dr. Sonia Malik, Dr. Sharda Jain, and Dr. Asha Bakshi, each a luminary in their own right. And I do look forward to their comments at the end of this presentation. I'm also delighted to share the forum with Dr. Gautam Khastagir, Jyoti herself, Dr. Narendra Malhotra, Dr. Jatin Shah, and Dr. Pahuja. I can truly say that I am in the presence of some of the pioneers and leading lights of IVF without any exaggeration. Thank you also, Yukti, for conducting this program so well as the master of ceremonies. I'm going to speak on hyper responders, the tricky lot.
Nakul, could you check? There is no volume.
Yeah. We also can't get his voice. So, Nishat, can you hear us?
And in fact, I think
now it's
better. Perhaps changed it.
Can you, is it audible now?
Yes,
audible.
Yes, now.
I will illustrate this a little later in the presentation. But before I begin, let me request everyone who's here to kindly support me as I stand for the presidency of Follicle. There is an ancient Romanian saying which says, abundance like want ruins many. And I think perhaps this saying was actually coined for hyper-responders. It is quite possible that the thought, more the merrier, has perhaps, to a certain extent, percolated into the management of hyper-responders. If you look at the data on hyper-responders in the literature in terms of number of articles, etc., you will see that most of it actually focuses on the prediction of hyper-response and also on the prevention and management of hyperstimulation. Current literature seems to suggest that anything more than 15 oocytes, following a standard protocol, can perhaps be labeled as hyperresponse. It is estimated that the prevalence rate in IVF cycle is around 7%, and it stands to reason that it decreases with women's age, as is shown in that graph with the blue markings. We know that young age, long menstrual cycles, PCOS, and a hyperresponse in a previous cycle are suggestive of a high response, but really speaking, practically, the strongest predictors of hyperresponse are still AMH and AFC. What is not as clear, however, is risk stratification as per either the AMH level or the AFC level. We know that when we talk about ovarian response, we should try and look at the most extreme values. Because again, response stratified vis-a-vis the test that we are using to define the response has still got a lot of controversies. AMH serum levels of anything more than 3.5 or 4 and an AFC value of more than 16 should perhaps lead you to at least counsel the patients about the potential risk associated with the treatment the chances that she may have a hyper-response, the risks of hyper-response like OHSS, and of course the fact that this may ultimately lead to a segmented IVF treatment where you would do an antagonist protocol with an agonist trigger, freeze all, and then transfer subsequently. It might be a good thought to wonder, where did this magic figure of 15 oocytes come from? Actually, it's been derived from a fairly old study by Lamarca et al. You'll see those markings in blue and red over there, where they tried to balance the chances of having a live birth vis-a-vis the risks or the incidence of ovarian hyperstimulation syndrome. Obviously, this was in the agonist era, and if you look at the graph now, it will probably look quite different. When I earlier said that the literature seemed to focus more on prediction, prevention, and treatment of OHSS in the patients labeled as hyper-responders, I meant that perhaps the literature has not focused enough on the other implications of hyper-response. For example, does having more oocytes give you a poorer quality of oocytes? So if you look at this quite old paper from 2009, you will see that at least in fresh cycles, the oocyte yield is proportional to the implantation rate. That means the more oocytes you get, the lower is your implantation rate. Again, remember that this was in the agonist era, and I suspect that a cumulative implantation rate of all the frozen embryos in the era of vitrification will probably look much different than this kind of a graph. Of course, when you talk of hyper-responders, you cannot help but focus on ovarian hyperstimulation. After all, if you think about it, the two biggest problems of IVF are ovarian hyperstimulation and multiple pregnancy. Multiple pregnancy and its solution seems to be self-evident. Transfer fewer embryos, you will get fewer multiple pregnancies. Ovarian hyperstimulation, on the other hand, seem to be a much more complex problem. There is a long history with ovarian hyperstimulation. You can see that first article is a reference from 1941. And you can understand why OHSS has caused such a fear in anybody who does IVF, because at the end of the day, it's an iatrogenic. Along with being a potentially life-threatening condition, it has a fair incidence, and it also has a fairly well-documented mortality rate. All these strategies have been proposed for both prediction as well as treatment of ovarian hyperstimulation, starting from minimal stimulation, avoiding HCG, delaying HCG, and so on. But really, what has changed the way we practice IVF is the ability to use an agonist trigger in an antagonist cycle, followed by the cryopreservation of all available embryos, avoiding a transfer and subsequently thawing and transferring in the next cycle. So again, taking a little broader view, if you think about modern IVF stimulation, it has to be all about both safety balanced with efficacy. And this includes prevention of OHSS, prevention of multiple pregnancy, which can be achieved both by segmentation and the use of antagonists for allele suppression. However, the thought of replacing HCG as a trigger is not really new. If you look at this fairly old study, which was performed for oocyte donors, even then you will see in that small study, the incidence of OHSS when GnRH agonist was used as a trigger was 0. Similarly, when an elective vitrification of all oocytes was done after GnRH agonist triggering, The ongoing pregnancy rate at that time, 2007, was quite reasonable. However, if you perform a fresh embryo transfer after an agonist trigger, then you ran into problems with pregnancy rates. And this seemed to be true irrespective of what luteal support you used and how much luteal support you gave. In fact, if you look at the data, you will see that till the addition of HCG came in agonist triggered cycles, pregnancy rates remained relatively low. All this actually led to two studies which I believe have probably influenced my practice the most. Both of them are from 2011, and the study which I'm showing you now is the one which actually proposed an OHSS-free clinic by segmentation of IVF treatment. Such a simple, elegant thought put together so nicely in this article authored by Professor Dafroy, Nicholas, and Christophe. Optimize the ovarian stimulation, GnRH agonist triggering in GnRH antagonist cycle, optimum cryopreservation, and then thaw and transfer in a non-stimulated endometrium in a natural cycle or with artificial endometrial preparation. But perhaps the study, which for me at least, is perhaps the most important study in IVF after the discovery of ICSI, has to be this one. It's not actually a study, it's more of a consensus statement, which talked about the fact and collated data to show that in an antagonist cycle, where you use an agonist trigger, the incidence of hyperstimulation is as close to zero as you can get. The margin of safety that this protocol imparts to stimulation by IVF actually makes it, at least for me, or has made it at least for me, an overwhelming reason to substitute all agonist cycles in my practice with antagonist cycles. In fact, with due apologies to the rest of the speakers if they disagree, I have now completely switched to antagonist cycles. I have not done a single agonist cycle, probably since almost 8 or 9 years. However, globally, nationally, the uptake of antagonist cycles did take a while to come along. You can see here the difference in the uptake of cycles over the years. From the latest NARI data that we have, it seems that we are still doing agonist cycles in 40% of our patients nationwide. So the question asks, to agonize or antagonize, why is it still a question? After all, if you can eliminate one of the biggest problems of IVF, that is ovarian hyperstimulation, by using antagonists, why do people still prefer agonist cycles? I believe that these were the issues. We were concerned about pregnancy rates, but it is now clear that the earlier studies, which talked about a lower pregnancy rate, were in fact the dose finding or very early studies. Now, when we know the dose and we know that a fixed day 6 start is crucial, pregnancy rates with antagonist and agonist protocol is the same or slightly better with antagonist. Is it cost effective? I believe that due to the fact that the number of injection days is considerably lower, there is no incidence of cyst
Dr. Jaydeep, we can't hear you.
Yes, Nishad, if you can please look into it.
Biggest hindrance in people adopting the Antagonist cycle was in fact programming of cycles. In India particularly,
Audible.
This is a very practical problem. We still do a lot of batch IVF in our country. This is relatively old data, but it's quite possible that the percentages remain the same. If you look at again the NARI data reported in 2013, from the 134 centers that reported data, the overwhelming majority of them perform less than 100 IVF cycles a year. Because of this, and because of the fact that there are several gynecologists, this is, for example, our IVF calendar. This is way back from 2017, and you'll see that marked in blue and pink are places where we are doing IVF. So you can see that we are literally doing IVF at some place or another in the country almost every day. And this, as I said, would not be possible without doing batch IVF. So the question came how to schedule antagonist cycles. And in the management of hyper-responders, when you want to do antagonist cycles, I believe this becomes crucial. So there are various options: oral contraceptives, E2 pre-treatment, antagonist, or delaying HCG. And we will go through each of them by turn. When we started using antagonists, I think it was probably in 2005, 6 or 7 or something, this whole issue of programming came up. I was always of the opinion that perhaps OC pills could be the best way to program cycles. Cheap, effective, known to be used for cycle programming to alter menstruation. However, not enough data at that time. So I actually went back and looked at the old data on oral contraception. Think about how we use oral contraception or OC pills for contraception. We say if you miss one pill, that's okay, take the pill. Take the pill which was due at night and you'll be all right. If you miss 2 pills, take 2 pills, take the pill which was due in the night and continue, no problem. However, if you miss more than 2 days of the pills, then there is a chance that there will be an escape. And although for cycle control, you can continue taking OC pills, for contraception, use something else. It clearly meant that within a few days, the effect of the OC pill started reducing and OC pill effect got washed out of the body. So if you looked at all the earlier data on oral contraceptive pills, they seem to raise 2 concerns. One concern was the fact that you needed a higher dose of gonadotropins when you used OC pills for pre-treatment. And the other concern was a higher rate of pregnancy loss. However, none of these studies actually showed a lower pregnancy rate till this meta-analysis from Grisinger came out. In 2010, and I must tell you, it was very disappointing to read this meta-analysis personally because I thought, there go my chances of programming OC pills and doing batch IVF with this kind of programming. He very unequivocally said that there was a decreased probability of ongoing pregnancy per randomized women in patients who received OC pill pre-treatment. But as I showed you the earlier data, the concerns were not so much about pregnancy rates as they were about other things. Data even after this kept on coming, which seemed to suggest that perhaps it was not an effect of the OC pill on the oocyte or even on the endometrium that was actually responsible. And then in 2011 again, a landmark here, I must say, for studies, this one came from Garcia Velasco, where they compared OC pill treated antagonist protocol versus a long agonist cycle. Remember, at that time, the long agonist protocol was the gold standard. So they compared the gold standard versus OC pill pre-treated antagonist protocol. And what did they find? They found that the outcomes were absolutely comparable. They went a step further and compared cycle scheduling with OC pills versus oral estradiol valerate. And again, they found that there really was no difference in outcome. So the same authors went back to Grissinger's meta-analysis. And when they relooked at this meta-analysis, they found that within the meta-analysis, there were several issues. Different types of OCs were used. One half of the studies included 30 patients or less. There were different duration of administration of OC pills in each study. But most importantly, in the studies included in the meta-analysis, there were varying pill-free intervals of 2 to 5 days. For me, it seems that the washout period of OC pills is extraordinarily important when you are using OC pills for programming. And again, quoting from another paper where Uman was a co-author, it seems that if you wait long enough for the effect of the OC pill to get washed out, then your pregnancy rates will be the same. So taking a cue from this and other studies and really speaking common sense, what we have done actually right from the beginning is to use OC pills for a minimum of 15 days and not start stimulation till the patient does not get her period. We typically give a pill-free interval of 7 days between the last OC and starting stimulation. There are, of course, other ways of programming cycles. There's luteal estradiol. There is estradiol pre-treatment, which both have been shown to be quite effective. And both of them have been effective in various kinds of gonadotropins. You could pre-treat with antagonists, and I still do this when I have to program for a very few days. There is, of course, the disadvantage of the cost of the antagonist when you use it for a prolonged period of time. You could coast, and I love these two studies because they speak of the minutiae of evidence that is available. So if you look at this study by Kolibianakis, where he coasted for 2 days in an antagonist cycle, he found that his pregnancy rate actually went down quite a bit. But if you advance or delay HCG by only 1 day, then it makes no difference to the pregnancy rates. So this was your classic antagonist protocol. And I'm only going to focus on the antagonist protocol for hyperresponders because I believe that that indeed is the way to go. We used to wait till menstruation, stimulate, fix day 6 start, continue antagonist till day of HCG, and if required, substitute the HCG with GnRH agonist. This is the protocol that we are currently using. Minimum 15 days OC pills. What is most crucial is that 7-day pill-free interval between the last OC pill and the start of stimulation, and the patient should get her period before you start stimulation. We also occasionally use estradiol valerate 2 mg BD to program the cycle. For us, the greatest reward for switching over completely to antagonists, particularly in hyperresponders, has been the fact that we have not had a patient who developed an OHSS which needed admission and antagonistic tapping since the last very, very many years. Of course, when you talk about hyperresponders, you cannot help but at least mention the ART bill and the impact that it will have on third-party reproduction. I strongly believe that unless we get a little more clarity from the rules which surround the Act, we are going to see a major detrimental effect for the patients in terms of cost escalation, in terms of accessibility and availability of donors, and oocytes, both, which will ultimately have a detrimental impact on the patient's reproductive life. I'm going to end with one of my favorite quotations from Winston Churchill, who said, "I pass with relief from the tossing sea of cause and theory to the firm ground of result and fact." And I do hope at least some of this presentation has been helpful for you to pass from the sea of cause and theory to the ground of result and fact. Let me end this presentation with this absolutely wonderful picture. I found it a few years ago on the internet, and every time I see it, it really touches my heart. This is a baby born to a lesbian couple in the UK. It took them 4 years, 7 attempts, 3 miscarriages, and 1,616 injections before this baby was born. After the baby was born, the couple who had saved all the syringes and needles which they had used and taken over the years, took the baby, wrapped it in that pride blanket that you can see, surrounded the baby with syringes and needles in the shape of a heart. And as you will see there, the photo went quite viral on Facebook. I'm always very moved by this photo because it speaks of what our infertility patients go through and inspires me to do the best that I can for them. Thank you very much for a very patient hearing. Let me again request all of you to please support me as I stand for the presidency of FOXI. I've developed a website. It's called isupportjaideeprang.com. Please do visit it if you get an opportunity. In fact, you're watching this on a laptop. You can use your mobile phone and scan that QR code. It will take you to my website. Once you're on the website, you can register your support for me, and I'm delighted, humbled, and honored to share that literally thousands of Foxians have registered their support for me. There is also a video blog where a whole lot of my presentations and a lot of the CMEs which I have convened, the O2S, the G2Y, the Bara on Bara are all available there. Or you could elect to join that Telegram group that I always put up when I'm going to speak in a webinar. Thank you very much again, Jyoti, for inviting me for this presentation. It's a real pleasure and privilege to be here, and I look forward from hearing from the experts. Thank you.
Sir, please unmute yourself. That was amazing. The talk always, I mean, you speak from depth, from like everything, whatever you say makes sense. And I mean, we really feel so blessed with you coming onto our platforms and giving us such sort of sea of knowledge. It is, and being so humble and presenting to us, it is really actually, we feel indebted to you. So thank you so much. Amazing talk. And I would like Dr. Sonia ma'am to give her comments now, since I think Dr. Sharda ma'am is not here. Dr. Asha Bakshi had to leave at 6 o'clock. So ma'am, Dr. Sonia ma'am. Ma'am, please unmute. Unmute.
Sorry. Do you think I should be saying something? It was a perfect exposition, wonderful. As always, Jaideep doesn't leave anything to chance. He just completes everything. Excellent. I really enjoyed myself, especially the pre-treatment part, which is not emphasized so much in our lectures, especially in the hyper-responders. You know, we all talk about pre-treatment in hyper-responders and poor responders, but we do need to have pre-treatment as well in some of these patients, especially when he said we are doing batch IVF, which of course, even though we may not be doing it to that extent now, and especially now with the new ART law coming in, where we will have to have 24 hours embryologist in every registered ART center, but still there may be circumstances where we would have to batch. So therefore, it is very, very essential for us to do that and to learn how to do it and to do it correctly. So thank you very much for that part. Thank you very much.
Thank you, madam, for your kind words. Thank you very much. Thank you, Jyoti. It was a real pleasure and privilege. Thank you. Thank you, Yukti.
Thank you so much, sir. So moving on to the last talk of today, Dr. Bharucha is here. Yeah. Nakul, can we have the CV? So our last speaker for today is Dr. M. Bharucha, sir. So after post-graduation, awarded PhD in reproductive endocrinology in 2012, and sir he's been inducted as a specialist in infertility and ART by the World Forum of Medical Scientists, Cambridge. Sir, I wholeheartedly welcome you to our forum and looking forward to hearing from you.
Is my introduction?
Yeah.
Okay, thank you.
Dr. Bharucha, sir, please share your screen.
I think Nakul can share the screen and Dr. Bharucha will be speaking because I think
I'm sharing.
Yes, please. So sir is going to talk on when to use and when not to use GnRH antagonist during the ovarian stimulation in IVF.
Good evening, my dear friends and colleagues. Today I intend to extend my heartfelt gratitude to Dr. Jyoti Malik for inviting me to address this august audience, and with whom I had a fairly long association, and at that time she was at a certain height of her career, and today, as we see all, she is at the height that is taller than the height of Eiffel Tower in Paris. Today I intend to share with you all my knowledge and experience gained over the last 32 years or so in assisted reproduction. And in those days, I had a long association with the giants of our fraternity, Dr. Farah Irani and Dr. Naina Patel. And from both of them, I learned more of assisted reproduction and enriched my experience further. I'm sure you'll all agree that in practice, we do come across a number of women who demonstrate a reduced response to FSH. And these women have been demonstrated to have acquired ionotropic deficiency of LH. And if in such cases, if FSH is supplemented by LH in twice the dose of FSH, the oocyte quality results in viable embryo with better IVF outcomes. Now I would like to share my knowledge and experience gathered over a very long period of administering GnRH antagonists. And I prefer to administer cytorelics due to my past association with the giant company Anis Siroro, which is now known as Merck Siroro worldwide. Ever since my initial training in assisted reproduction in Bourne Hall Clinic, located in Cambridge, England, 32 years back, under the medical director Peter Brisden, I acquired knowledge and experience of the long mid-neutral separation protocol in IVF cycle. I am sure many of you will agree with me that with this protocol, it was observed way back in the 70s that the requirement of gonadotropies was much higher with the protocol that we are talking about and what it was with HMG alone. And the prevalence of hyperstimulation syndrome in PCO women was intolerably high. These developments led to the development of GnRH antagonists. Yeah, sorry. These developments led to the development of GnRH antagonists, which could be administered as either a fixed protocol or flexible protocol. The fixed protocol is being preferred even today over the flexible one, as it has been demonstrated to be simpler to follow for all women regardless of the disorders, entailed by better results in terms of increased pregnancy rates and live birth rates, and that too with the reduced requirements of gonadotropies. Furthermore, the major beneficiaries are the women with PCO, in whom hyperstimulation is considered imminent. In this population, when GnRH antagonist is administered from day one of controlled ovarian stimulation, significantly more mature oocytes are recovered, resulting in more viable embryos, leading to better IVF outcomes as compared to the unsatisfactory response observed in mean nuclear separation protocol. In all PCOS women, do administer GnRH antagonists from day 6 if you are using fixed protocol, or 1 day before SCG trigger, depending upon the E2 levels if you are measuring. If you are measuring E2 levels or the desired sonographic markers during controlled ovarian hyperstimulation IVF cycles. In case of flexible protocol, the GnRH antagonist could be administered either from day 5 or day 6 of controlled ovarian hyperstimulation. And if the E2 levels are found to be exceeding 500 to 600, and also the number of mature follicles exceeding 4. Now, let me inform you all, ladies and gentlemen, that as per recently developed paradigms in women with abdominal pain and in disorders such as endometriosis, adenomyosis, and uterine leiomyomas, do administer GnRH antagonists in the dose which you are using for in IVF cycles to give them relief from pain. Now let's talk about one of the contents of follicular fluid, which is vascular endothelial growth factor, whose expression is seen in follicular fluid of all women and which has been observed to be attributable to site maturation induced by SCG trigger and with normal endocrine profile and sonographic paradigms. However, in PCOS population, SCG is administered for oocyte maturation. It is known to cause overexpression of VEGF, leading to increased vascular permeability and thus resulting in abdominal ascites. Furthermore, in this population, in whom VEGF expression is altered, it has led to unexpectedly under response or subdued response. Therefore, do administer GnRH antagonists instead of SCG. This paradigm shift was first observed by known national authority, Professor Jacob Howards, under whom I had the pleasure of working, and I was even given ample opportunities for my further growth and acquiring his academic knowledge for enriching my academic knowledge further and more enhanced previously gathered experience. And this observation by Professor Howard was subsequently confirmed by other stalwarts, Tokoyama and Nakarawa. Now let's take up the issue of when not to administer GnRH antagonists, which in my view is very important to all of us who are practicing assisted reproduction. Never administer GnRH antagonists in hyperestrogenic disorders such as endometriosis, adenomyosis, and uterine fibroids during controlled ovarian hyperstimulation in IVF cycles. When controlled ovarian hyperstimulation is preceded by the administration of aromatase inhibitors, which are known to convert androgens into estrogens, because GnRH antagonists will reduce FSH levels further to lesser levels and profoundly reduce LH level, eventually rendering the recipients either subdued or poor responders. The next point that I would like to stress about is kindly do not administer GnRH antagonists in subdued or poor responders in whom FSH and LH in increased doses are essential during controlled ovarian hyperstimulation in IVF cycle, which are necessary for achievement of at least 3 to 4 mature follicles or D4 or D5 for better IVF outcomes. In young and adolescent women with PCO morphology and ovulatory cycles, never administer GnRH antagonists as it may result in ovulation and subsequently amenorrhea. Thanks very much for listening to me, ladies and gentlemen, and I wish you all higher growth and higher success rates. And I am now open to discussion.
Thank you, Dr. Bharucha, for an excellent insight into the gonadotropin analogs. And I'm sure I don't see any questions in the chat box though, but I would certainly take comments from our expert, Dr. Sonia. Sonia ma'am is there. Yukti, I think ma'am has, I think, left, no?
Yes, ma'am.
Yes, Dr. Sonia ma'am left.
Left. Yeah. Okay. But I think any other comment you can see, Yukti?
No, ma'am.
No.
Sir, it was an excellent presentation, and thank you so much for taking out time and teaching us. It was a pleasure, real pleasure, sir.
I think, sir, since we don't have any questions for Dr. Bharucha, and we are at the end of our webinar, I think, Yukti, since we have already overshot half an hour from our time,
yes,
maybe we will just say thank you to MCure. And we'll
I would like to thanks to Dr. Jyoti Malik
let
and
me
Dr.
first thank Yukti as well, then I'll thank MCure.
Yes.
Let me thank Yukti, and so that then MCure can say vote of thanks, and thanks to all the experts that took out time, all the speakers that took out time, and all the participants, the delegates who took out their time to listen to this very important webinar. And hopefully it must have helped. And again, we will come on again maybe on 23rd of Feb with another issue on the same very platform, Fertility Forum. Yeah. And
thank you so much, Jyoti ma'am, for having me here and giving me the opportunity to learn from all our esteemed speakers and expert commentators. It was a evening worthwhile. And thank you so much, MCure, for supporting us. And I guess we are all, with each other and spreading the word and educating more of our colleagues and our friends, and so that we all pledge to do good and do better each day. So thank you so much, Jyoti ma'am. And yes, Nakul, over to you.
Yeah, thanks, ma'am. I would like to thanks to Dr. Jyoti Malik and Dr. Yukti, as well as that it was a wonderful webinar that we have seen many talks today. That's and many stalwarts. They have given a speech on burning on burning topics, the ovarian stimulation protocols. That's a good learning to us also. Yeah, thank you, ma'am. Thanks, Dr. Jyoti, ma'am. Yeah, thanks.
Thank you, everybody. Thank you, Abhishek, Dr. Abhishek, Mr. Deepak, and Mr. Nishad from MCure.
Yeah,
along with Nakul. Thank you so much. Thank you.
Thank you so much, everybody. Looking forward to meeting all of you again on 23rd. Good luck.
Surely, ma'am. We are here to. We are here, ma'am.
Sure. Thank you, Nakul. Thank you, Jyoti ma'am. Bye-bye. Good night, everybody.